great. I'm a little tired today.
Did you go to the improv class?
Yeah.
Yeah, I couldn't go because they had a client at 2 o'clock.
Then I hung out with people afterwards, and it's a long day. But
Yeah, it's a weird because you're there from 2 to something, and then you get a long gap before you come here, and it's like, what are you doing between? That's the problem.
I go to the Arts Institute, but I was hanging out with them. Yeah, it would be nice if there was some place I could take a nap.
Except that I worked late today instead of early, so I got home.
There's no way I could fit clients in on a day like today, so it's my day.
Yeah, I used to have someone at 7, but he switched to yesterday, so I have a 2 o'clock today. Switched to Wednesday.
Just a halfway point on classes. And
Well, we're getting closer. Let's see. What do you say, Justin? Where are we?
How many are there? There's about 47 or 8, something like that?
Yeah.
Total? So yeah.
I regret I missed the beginning.
Well, it's all on YouTube. You can watch it.
Yeah, you gotta watch it on YouTube.
Right.
All
I like to
right,
watch
everybody.
2.
Well, you will see
All right.
those 2
I got
on
so much out of
YouTube.
Don't worry if I'm upside down a little bit. The rest of the class will be right side up.
So much out of it.
Anyway, what are we looking at today? We're looking at
23.
23, back of the thigh pain. Back of the thigh pain. You know what most people call back of the thigh pain?
What do they call it?
Sciatica.
Yeah, they do.
It's not really sciatica.
Well, it's the shape. It's the shape or the feeling of sciatica.
Yeah, it can be. So we enjoyed going muscle by muscle last time, so we're going to do that same thing this time. So there's our list.
Yeah.
Gluteus minimus, semitendinosus,
You look at this one.
semimembranosus. Really, you guys know that these are the hamstrings. Which side are the membranosus and tendinosus on? And again, it's just like the we see this arrangement of muscles in a couple different areas, where one is thinner and more tendon-like, and one is flatter, more pancake-like. And where do we see that? So we see that in the calf, where the gastrocs, there's one medial, one lateral, and both of them are kind of roundish. And then what sits underneath the gastroc? The soleus, and that's flat like a pancake.
What chapter?
Where else do we see that? We see that in the biceps, right? We have the biceps, which is a long, thin muscle that goes down the arm.
Like.
See? Well, I was talking about this biceps brachii. And then underneath it, on either side, this side and that side, underneath it, flat like another pancake, is the brachialis. Okay? So once again, the third area where we see a thinner, ropier muscle on top of a flat pancake-like muscle is the semitendinosus and the membranosus, which are both hamstrings. And which side are they? On the medial side or the lateral side? I mean, the audience dare a guess? We have
So.
semitendinosus and membranosus. Yeah. And then we have biceps femoris
On the outside.
on the outside. And what do we need to know about the biceps femoris? It has 2 heads, right? Doesn't it? It has a reflected head and the... Let's see, am I right
2
about
heads are
that?
better than 1?
2 heads. And that's why they're called biceps, right?
Oh, did we lose it?
Yeah. I'm gonna go look at an image of it.
Okay. Well, that's.
There you go. See? Short head and long head. The long head goes on the ischial tuberosity, and the short head goes right on, attaches kind of beneath the, under the femur, beneath the greater trochanter. Okay, biceps, 2 heads. Triceps, 3 heads, right? That's why they call that. All right, sep. Sep
What does
means
that
divided.
attach onto the?
Oh yeah, that's the lateral side of the leg there. This one's called pes anserine on the medial side. Does the lateral have a fancy name?
Doesn't this much, but
Doesn't,
it's
right?
just it attaches onto the tibia and to
Sure
the
does.
fibula.
Sure
Yeah.
grabs onto the fibula.
Well, the biceps.
Short head, yeah.
Short head.
Yep, and that's important too. Sometimes you can have really bad fibula pain. Okay, I go back to this one. Okay, great. We still got 2 more minutes, so let's see. What else have you guys been doing? Did you go to the MyoPain website and make sure you get all the forms right? Now, if some of you wanted to watch this on your laptop, remember you could always go right up to here and you could just type in Periscope. And then .tv/your NSCA. And that will take you right to where we're broadcasting. Oh my gosh. /your NSCA. See, there it goes. And that will take you right to where we're broadcasting. Oh my gosh. /your NSCA. Okay. All right. So, right here on our website, here is the newsletters. All great articles that you can read on all sorts of different subjects. And again, you can also have these sent to your patients. If you forward our heading, you can do that, or you can have your own heading for we charge you just a little bit of what it costs us to do it, but we'll put your banner together for you and send them out. And oh, you could have Frankenneck syndrome. Look at this. And then you can send your patients information on how to fix Frankenneck. And we'd have that frozen muscle. There's a great levator scapula, those muscles you have to treat on the short and the long, otherwise it freezes it kind of in the middle. So how they can test it, how they can treat it, yeah. And most of all, keeping them in that positive mindset that you can fix these things, and also reminding them that you're available if they want some help with that. And then also on our website, of course, we have the wonderful Bodyworkers Mastercourse, and there we have all sorts of useful things like charts, all the protocols. Number 23 is right in here. Patient management and eval forms, tracking forms, stuff, and range of motion testing. That's not the charts, but pictures. But those are the. It gives you each test listed, and then the muscles that are indicated, how to test it, and the pass-fail ranges, and then you can write down, also, as well as a place to write down how they were before and after treatment. So if you like to do that, that can be very useful. Now, some people complain the second one doesn't open, but it does if you download it first. Okay, it doesn't for some reason in in Chrome or whatever browser, but you can download it. All you do is you just you click on the little download thing, right click, and download, and then it'll open up fine on your computer. All right, so it's time to start. Here goes the class. Pain key number 23. There's only
Posterior thigh pain.
Yeah, posterior thigh pain. There we go. And your teacher of the hour.
Posterior thigh pain today. So what are we doing? We're showing people how to fix every pain problem in the body caused by myofascial dysfunction.
Yeah.
And we're going to be doing it all the way to March 7th.
Oh, yeah.
Is it incredible?
Yeah,
We'll have the whole thing done by then.
Oh, yeah.
It'll be, you'll be participating in all of it, and you could also look at the archives later on.
Yeah, we'll be knocking out your CEUs for this year and next year, most likely.
Yeah.
Well, depends on state, but yeah.
Hopefully.
And we're getting on those right now.
Yeah. So what's the most likely muscle to cause posterior thigh pain? So back
The sciatic muscle.
Yes. So that would be pseudo-sciatica.
Yes.
Okay. So we're going to look at that muscle. That's gluteus medius. So that's
minimus,
the muscle.
sorry.
Minimus.
I
Yeah,
screwed it
gluteus
up.
minimus. So that's right here. So that you find the greater trochanter and come up a little bit, and that's the attachment of it right there. And it does a few things. It turns the foot in, turns the foot out, and takes the leg out to the side.
Oh, yeah.
And helps you when you're walking. Level your pelvis. So that's one of the muscles we're going to look at today. And let's look at the range of motion of it.
Yeah, okay.
I meant it's
referred
referred
pain.
pain pattern. I meant
Yeah,
to say.
yeah, yeah.
Okay. So here's the referred pain pattern. And you can see how this one comes all the way down the leg. So it
Or
can
minimus, sorry.
minimus, it comes all the way down the outside of the leg to the ankle, and it can come and get really bad on the back of the thigh right there.
Yeah.
So that's our minimus. And
this is the one that people confuse with sciatica, right?
yes, it's often called pseudo-sciatica, but you know, it's actually causing the pain of sciatica.
Yeah.
So it depends on how you want to define it.
Yeah.
You
True
know.
sciatica would be more like a shooting nerve pain, but achy pain often gets misdiagnosed as
Right,
sciatica.
but that's correct. See, it doesn't have very much nerve component to it.
Right,
Yeah.
right. The piriformis would be more involved in
Oh, yes.
nerve. If you
Yes,
actually
right.
had
That's
sciatica, you might just have a tight piriformis.
Oh, yes.
But if you have this achy pseudo-sciatica pain,
Mm-hmm.
you probably have a gluteus minimus. And what's the range of motion test? I love this
Oh,
one.
this is a great one.
Yeah,
okay,
'cause anyone can do
so
it.
who can show us the range of motion test out of what book are we using here? Okay, let me give me one of these books. Oh, I've got it right here too. So this book, what are we? This is trigger point therapy for low back pain, and in here you can get this through Amazon, and you can see where the muscle attaches right here on the greater, and over here onto the pelvis here, and it's this is in the trigger point therapy here for low back pain, and you can get that on Amazon.
Yeah, yeah.
I think about
You can get Sharon's
$15
book.
now.
Yeah. Yes,
Yeah.
thank you. So this is a great book. It is.
Yeah, so the range of motion test that we're going to do is 45, 46, and 51.
Yeah.
And we'll want to look at nerve roots L4 to S1. We want to look at the rotatories and the multifidus and the fascia around the bones in those areas. And see.
L5 to S1?
So we're looking, yeah, so we want to see. we
L4
want
to
to,
S1.
oh,
Yeah,
L4, S1, L4, L5, S1.
Yeah.
And
great.
then we're going to use the skin rolling and see if the skin rolls there. If it does just fine, we don't have to bother with it.
That's right. That's our
Okay.
magic, what do they call that? Myograph. We
Yeah,
can do that,
again,
yeah.
here's our referred pain pattern down the outside all the way to the ankle, and a little bit more of the posterior here area goes here to the back of the leg. So So this is our range of motion.
Yep.
We looked at the muscle. We talked about its range of motion.
Or referred pain.
Referred pain. Now we're going to do the range of motion test.
Yeah, yeah.
Okay. So one test is just, can we turn our toes in really easy? So this is one test. Isn't that a great test?
It should be the
What's
same
all of
on
this?
both sides, right?
Yeah, yep. And so see how much we can turn them in.
And for
Okay.
the most part, they should almost be able to get 90, right?
Well, you know, they're pretty, I mean,
Pretty
just
close.
a pretty good, you know, it shouldn't be painful. We should be able to get them in.
Yeah.
What if you can't even get them in at all?
Right.
You know.
Then that's obviously
yeah.
not right.
Yeah, yeah. So let's look at a couple of the ones
And if
on.
one side's worse than the other, it's obviously not
yeah,
right.
what if you can't get one?
I
one
don't
is-
see a lot of
of
internal
those-
rotation here, for example.
Yeah, so
Would
we
you
could do a
say?
little better there. Yeah. We could do a little better here. So if we can get a little more range of motion
Yeah,
here.
I think
So it's our goal
all of
today.
us looks like
more
look
than
like
All
they
of
could-
us could get better today, don't
Yeah.
you think?
Yeah,
yes,
definitely.
we could.
Yeah,
Okay.
sure.
So let's look at the range of motion 45, 46, and 51.
Okay.
Let's look over here. So let's look at 45. This was the Bonnet's sign. We want to see if we can internally rotate. We want to see if we can get this. You put the foot here and then bring it up to there without pain. We're trying to get the foot to rotate in,
Yeah.
but from the hip, okay? And then what was the last one? Oh, this one here, the coffee table test for the piriformis and the gluteus medius and minimus, you could say.
But
not
it's
as-
actually supposed to be 50, isn't it?
Oh, no. Here it is. Okay, 51.
Oh, yeah, 51.
Leg
That's it.
crossing, the
That's
leg
leg
crossing.
crossing
Yeah,
test,
so we
yeah.
could do the leg crossing one.
That's the main one that's so easy.
Yeah,
it's
yeah.
so interesting. People sit like this all the time, and you can see the gentleman here has a huge gap between his knees when he crosses
Yes,
them.
that's right.
And that's a sign that your gluteus minimus is
And so
really
what
tight.
we'll do is measure between the lower leg and the upper leg, and see if there's. The goal is to have no space.
Yeah,
there.
you could use your fingerometer.
Fingerometer.
Yeah, fingerometer to see how many fingers you can
Okay.
get between there.
Okay, so the ones we're doing is the 45, 46, and the 51.
Yeah,
Yeah.
especially 46 and 51 we use a lot.
You know, this we use incessantly.
I mean, incessantly. And this one's cool to demonstrate.
That's nice. Yeah.
You know.
Okay.
Anybody want to demonstrate?
Who would like
these?
to do the
We were
leg
doing
crossing
these.
one?
Sure.
And-
Okay.
Okay, she's going to show us the leg
Why
crossing
don't you
one.
sit on
Oh,
this
yeah, I better
chair
sit on
because
this
you'll need
chair.
a more sturdy. So this is test number 51, leg crossover test.
Leg crossing. Okay, and for here we have a little bit of space. Oh, not as much space as last week. One finger.
One finger,
One
not
finger.
bad.
One
Okay.
finger, that's better than last
Better than-
week.
Let's try the other leg. Oh yes, only hardly a finger.
All right.
Yeah,
Good,
we're
good,
progressing
good.
here.
Anybody else want to sit? You want to try? How about
Oh
you?
yeah, Kirk, he's gonna. Oh, go ahead.
We can all do it.
We'll all
I think
take
I'm gonna have to fail.
Okay. He's gonna fail.
It's we've been changing the language. It's not fail. It's not passing.
Okay.
Oh yeah, see.
He can't.
Okay, so we're gonna measure from here, so we could measure from here, this leg in here, so we could do, you could say it's a whole width of a hand.
Yeah, you almost
Okay.
need a handometer there.
Yeah. And then right here, the whole width of a hand, right
You know,
here.
why do I get the feeling that men would fail this more often than women? We just never sit like that, right? We never stretch our gluteus
But-
minimus because it's supposedly unmanly.
But keep in mind
To sit
that
like
at the
that.
Bonnie Prudence School, we tested children at every age.
Yes.
And the boys at grade 2 all started to not be able to touch their toes.
Uh-huh.
But all we did was give them a program of 6 weeks where they did range of motion exercise, and every single boy could touch his toes
Wow,
and
so-
could do. So it's
Yeah.
not. It's sort of. I think it could be corrected.
Yeah. Especially when you're young like Kirk and myself. I mean,
That's it.
this is just... All right, should we do one more? Or,
One more.
should
Let's
we-
do one more.
Let's do one
We'll do
more.
one more. Let's see. So
Linda
a
can-
whole hand for you, and that's for you. Oh, better than last time. Okay, so half of a finger.
Wow.
Oh.
Okay. Okay, and here 2 fingers. Yeah, on the left.
Okay. All right, good.
So we're pretty good. We're coming along. So let's see if we can get a little better.
And
so
how about the
next
leg
one-
turn-in test?
Let's do the leg turn-in test. Okay.
Is it good enough
sometimes
to do it standing, or should
no.
we?
It's
Nope.
well, okay. It's a good start, but it's
Okay.
not good enough.
Yeah.
Okay.
So I think there's more factors when you're standing.
Yes.
When you're lying, there's
Okay,
if
so
you can
we'll move some of these over to the side
remove
here.
some of the other factors.
Yep. My
And
materials
I'll show you,
here.
in the meantime, I'll show you guys the referred pain again. It's such a neat pattern.
Okay, so can we measure? Okay, go ahead and lay on your
These
bed.
are more in the anterior portion, and these are more on the crest portion. Up there.
Put your head all the way up here.
See? Those two guys, and then more.
Scoot a little higher up. Okay, so this is the Freiberg's test, or the internal rotation, turning your toes in. So one would be they do the action. So here they're doing it. So you measure from the metatarsal head. So that's like 4 inches on here, and about 4 inches there. But usually I do it this way, passive. So I usually do it myself. But then you could try different. Just make sure you do it the same way when you're retesting. So here I could go ahead. No, I'm doing it this time.
Okay.
Okay, so then what I do is I just give it a certain amount of pressure, and I can feel the resistance there. So if right from there, so it's like about 6.
Yeah, she's not grabbing the ankle
6
because
inches.
that would be more ankle rotation.
Yeah. Then
We're looking-
we're just looking at the ankle and the foot rotation,
which is fine for
Yeah.
some peroneal and
Well,
other
we
tests.
can look for that for the peroneal
Yeah,
test.
yeah,
That's
exactly.
great for that. Okay,
Yeah.
so but for the gluteus, for
Minimus,
the minimus
yeah.
test, we want to see the internal rotation, also for the piriformis and the gemellis, and also the obturator internus. Okay.
All the external rotators.
Yeah, we can all check them all out. So here we're going to go from the metatarsal head, and again we're going to rotate from the hip, okay? And then we're going to measure, and it was about 6 inches on the other side and 6 inches on this side.
Yeah.
Okay, so that's a nice goal. But what's the goal is we want to get it to go easily all the way down to the table.
Yep.
That'd be a good
Should
goal.
just be able to rotate like that.
Table.
Yep.
Yeah.
That's
Yeah,
the
we'd
goal.
like to do that.
It's
Yeah.
a goal.
It's a goal.
Okay.
Okay, let's go ahead and turn to one side and use your hands and get up. Yeah, great, super. And I have a little stepping stool here if you like.
Okay.
Okay, so who else should we check?
Okay. Let's
Check
take
one.
my shoes off.
Okay,
Check
so
one
can
more,
I
and
have,
then we'll.
Linda, could you measure her?
All right, Linda's going to do the test.
Okay. So what you're gonna do is, I'll do one side, then you do the other. Okay. So you're gonna have them. You're gonna. So she's not gonna help.
And I'm not gonna help.
Okay. So this is just a range of motion test, passive. So relax. Let me do it.
I'm relaxed.
Okay. Okay. So you're about to there, and then you see, from the metatarsal head there, that's about 3 inches. Okay. So you could see. You go ahead and so you're rotating at the hip right here. Okay, and then we could have her do it actively too, just to see the difference.
Okay.
Oh, that one's coming pretty close.
Yeah, it's almost to the table. Wow.
Yeah, so it's only
2 inches?
a finger. That's half an inch. Like.
Inch and a half?
but it could be.
Well, less.
you
Here's the metatarsal. Yeah, it's only like
you
more
could
an inch.
But you might be measuring it different with more pressure than me. So you could try this side. See
Yeah,
if
go
I
ahead and
can-
try that side.
Just for fun. We'll just see.
Well, this leg had polio. So my-
Yes,
that leg
this one's
turned
more
out.
stiffer. Probably, yeah.
Yeah, I always walked with the right foot
Yeah.
turned out.
So you try
Different
this
range
side.
of,
Just
different range of motion on this side.
Yeah, it looks. Yeah, so go ahead and check that.
I'm a left-handed measurer.
By the time you do it the second time, a lot of times you increase
You
your
get
range
a
of
little
motion.
bit more.
Yeah. So it's the first range of motion, it's the first test,
Sure.
but that's still.
So does that look like 3?
Oh, let me check.
I don't know if I'm measuring too high.
Yeah, 3. Yes,
Okay.
about the same.
Very good.
Perfect. Okay. All
Okay.
right. So let's turn to one side and use your hands and let's get up. Yeah.
Okay.
Well, great. So should we look at you too?
Sure.
Okay.
I should take
Do you
my
want to
shoes
measure
off.
her? You feel like measuring her?
Here, let me get my shoes.
Great. Come on over.
Or you know what? We're on camera, John.
You'll be
so I'll
fine.
use
Yeah.
my shoes.
It's all right. You can do this with shoes on.
It feels
But
okay.
sometimes
No
we can do
problem.
it with shoes.
Yep.
Is it okay?
Yeah, that's all right. We're doing it with shoes today.
The one thing we
Next time-
can't do is without you.
Yeah, just measure my
Okay.
shoes. I won't
So
be able
here,
to.
so you feel the resistance right there. That's where you stop. Okay, so can you want to try it for a second?
Sure.
Just feel the resistance, and then you can stop right there. Okay, so right? Can you feel it? So you're stopping a little further. Yeah. So that's good. I like the way you're doing it. So you go from the metatarsal head to like 4.5 inches.
They call that end feel. Do you guys know
End feel.
what end feel should feel like?
And feel.
Any joint should
Where
go
it stops.
through its full range of motion to a soft, slightly springy end feel. It shouldn't be bouncy and tight and taut. It should go to its end. It should be like a soft, like if I just push
It could go further.
Yeah.
It could go further.
a little bit further, but it should
Yeah.
feel just like that.
Yeah.
That
So
kind of
then
feeling
that's
is good
like
end feel.
4
If
inches
it's like
when you
this,
hold it
and
there.
it's like,
Yeah.
it doesn't want to go, yeah.
Okay, let's try on the other side.
Alrighty.
And let's see if how you could do. Could you measure with one hand and hold the?
Maybe with a ruler.
No, you would
No.
try it. Yeah, let's try it. Yeah. Okay.
Yeah, you could use a straight thing if you wanted
Yeah,
for this
can we
one.
use a straight
Yeah,
ruler?
let's see.
That would be
Oh,
easier.
and I'd like to make note. This is the
Okay.
International Myopain Society. No, you don't warm it up first.
Oh, okay. You
The
just do it.
International Myopain Society measuring tool, fibromyalgia and myofascial pain syndrome.
Ah.
Okay, here we go. It's like 6 inches. That's a good tool. Thank you,
Yeah.
International Myopain Society.
That's
That's
rule.
www.myopain.org.
Yes, they roll.
Just like our website, but instead of
This was
saying
6 and this was 4?
myopain.com, it's .org.
Yeah,
It's
.org.
a-
Okay, I got
So
you.
it's a good
Let's
organization.
try this.
So like 6 inches on this side and a little bit less on this side here.
All right.
Good. Okay, so that what's our goal? We're gonna have it come all the way down to the table.
Down
Think we can
from
get
Never
there?
do
From the
something
hip.
with my knees first before that's going to happen, and my
Yeah.
ankles won't go for that far.
All right, so are we doing self-care first or patient care? Or,
Let's do
Therapist.
let's do self-care.
okay, self-care
yeah.
first?
Yeah.
Okay.
Okay, so if you could just go ahead and sit up for a second
This is good.
and use your hands. And sit
What
up.
what
You-
tool
you
would we
leave
use?
Leave your legs out in front of you. So leave them right here where they were. Sit up though with your legs out in front
Swing
of
your
you.
legs around there.
Well, it's okay for your shoes.
Yeah, but
Okay, well, let's
do
put
you want
a
my
new
butt
one.
here? You want my butt here?
No, your feet.
Oh, okay.
So someone's shoes probably were wet.
Oh, okay. What do you want?
Leave your
Yeah,
legs out in front
exactly like that.
Oh, okay. The same
And
thing
sit
we
up.
were doing before.
But sitting
Sit
up.
Yeah, sit
Okay.
up. Here I am.
of you. Okay.
Perfect. Ta-da!
Where am I?
That's
Okay.
all right. It's all right.
I'm having a myofascial moment.
Okay, so we're gonna lift your leg up here. We're gonna heat it up a little bit, and so it's a good way to treat it
Yeah.
right through the hot water. So a lot of times your hamstrings could be kind of painful. So one way of treating it would be
my knee feels very tight.
oh it does.
How about these hot water packs? Does everybody know where to get them?
Yeah, let's find out where we get
Let's
them.
show we can get them from this website called healthandmed.com. Or you could probably get them, somewhere else you might find, but
Thank you.
Health and Med. Oops.
Yeah, Health and Med and other great locations. Okay, so here you go. You can hang on to your
Maybe I should
foot.
take my foot
Health and Med.
So that's kind of good. Now you could. I think you're going to be a little more fun.
And we search for Fomentec.
This one has a little bit too much hair. I'll put it
There you go.
Okay. Okay, here's a nice tool for you.
All right.
And here, give this one to Camille.
So we're using a stretch it strap, or you could
Yes.
use a belt, or you could use a jump
or
rope.
just any kind of tool like that.
Yeah.
And if you go ahead and take a look at your product, you might have downloaded this off the internet.
Yeah.
And remember, the most likely one is the one on the top,
Yep.
the first one, second one. So sometimes maybe just hit the first three, and you're likely to get the pain problem.
Yeah.
But sometimes it's just the last one that's causing the problem.
Yeah.
So it is good to hit them all. So here
Those
we're
are
going
hit
to
'em
take a
all
look at
totally.
we're going to take a look at this is
Minimus.
we're going to go ahead and take a look at the glute minimus. So we're going to we're going to go ahead and press, and we're going to use different tools. So one of us is going to do it on the floor.
Okay.
And keep in mind though, the glute minimus and the piriformis and the internal obturator are all in the same buttocks area.
Exactly.
So we're going to treat the buttocks on
It's kind of nice to think of it
together.
as a region,
A
and
region.
cover all the
Yeah.
spots throughout that whole region.
Yeah, that whole region. Okay, so we're going to use a couple different tools for that, and
Okay.
I'll do it on the floor,
Great.
and other people will try. We'll start them up in different positions. Okay, so let's go ahead and let's have you start using. I'm going to have you use a ball and a pillow. Okay, so if you look in the book, you'll see different ways of treating the gluteus medius and minimus and piriformis, but turn sideways. Just turn sideways. And go right above the greater trochanter. Right there. Okay, how's that painfulness of that?
It's okay.
It's okay, right? So what you're going to do is cover that whole region, and let's see if here it is. So you're going to cover the whole, look over the whole top of the greater trochanter. So the front part of the greater, up above it, and behind it. So you're going to get all above
It
it.
doesn't go as quite as high as the crest. That would be the
Yeah.
glute medius. So
That's right.
Kind of in between the greater trochanter.
Yeah,
and the
so right
crest.
in the center. So you're going to move in different positions and look for painful spots and press on them. And then we're going to check to see if we get better range of motion.
Okay.
Okay, so you do that.
Does she
Okay.
prop herself up on her elbow if she
Well,
wants? Or?
you're going to move in different positions.
Yeah,
Okay.
yeah.
So to
Yeah,
get
exactly.
you're
There
going to
you
use
go.
yeah.
Whoa.
There you go. Good. And you find the right ball and surface combination. This is a soft surface, so a harder ball is good. If it was a hard surface, you might need a softer ball.
Okay, so in our book here we have we show you how to do different things to help with it. But one of the things that you're doing is so here's all the areas we're going to treat in the butt. So we're going to treat the whole bottom of the butt, all around up in there. So the gluteus. This is for the gluteus maximus. We're going to treat everything in here, especially the piriformis, and then lower down here, we'll be getting the obturator internus. Okay, and then up here we're getting the minimus. And then here's the piriformis. So here's all different ways to do it. She's doing it with hot packs.
Yeah.
She's treating the butt with hot packs to begin with. That's beginner level.
Uh-huh.
And then we could go more advanced, a little bit more intermediate. And then here we could do this on the wall. And then
I really
more
like that one on the wall there.
this here on the
Oh, yeah,
wall.
I love it.
And then the next thing is we can do it on the floor.
Yeah,
and with
that's
pillows and stuff like you're doing here. And you could use a bigger ball. And I didn't want to give you a bigger one. I figured fall off the table. But this is a good way. Another tool you can use is this jackknobber on the wall.
If you're more
And then-
masochistic.
Yes, that's true. That's true. Here's you can use a foam roller. Doesn't get into all the nooks and crannies, but you can see you can lean and spend some time, really spend some time with that. But the balls work a little bit better. And then you could go a little bit more with the back knobbers. And again, with other tools like this, you could make it softer. Again, you could use things. Now we're working a little harder, a little bit more aggressive.
On the stretch, folks, right?
On the stretch.
Look at this one.
Here.
Great stretch.
We're really putting it on the stretch and really ironing it between the greater trochanter and the sacrum.
Oh, yeah.
Okay, we're going to iron it and look for those painful spots. And here we're trying to get you to pass these range of motion tests, get the knee to the opposite shoulder. We're trying to get you to be able to get your toes all the way in. So, and here's some beginner level of stretching and strengthening. So this is everything you need to know about getting rid of gluteus medius pain here.
Yep. But
Okay.
frankly, you guys are doing better than 90% of people out there just by isolating it, compressing it, any amount of treatment. Muscles love to heal. So it's really, you know.
So let's get on the floor. Any of us that want to do the floor work?
Someone like to do the floor?
Yeah, I'm going to get on the floor, and the rest of you could do it on the wall.
Yeah, yeah.
I'll do
that's-
the
Go
wall.
ahead and do both
Yeah, the
sides.
wall is so
I'll do
cool.
the wall.
And then remember, here's your
Yeah, I
side.
feel like I'm too high up.
Yeah, well, then get just right above the greater trochanter, and then get way back here. You want to go way over here.
I think I would be a better wall person.
Which wall?
Okay,
Oh,
good.
you can
Let's
come to the
try
wall.
the
Yeah, I
wall.
think
Let's
they-
try the
yeah,
wall.
because
She's going to try the wall.
Is this good for the
Because I
wall?
don't feel like I'm
Very
really
good on the wall.
getting anything.
Okay, that's very good on the wall. It's too soft, so she's not getting enough. She's going to go to the wall.
Well,
Okay,
To the
good.
wall, lady.
Okay, so here we're gonna go to, I'm gonna do it on the floor. So you can follow me, so you can go right onto the wall, right above your greater trochanter. So find your hip bone, and you're gonna get right above it. So get right above your hip bone, and you're gonna really feel the attachment right on the hip bone, on the greater trochanter. Really feel it. Let's come
oh
posterior.
no, I feel like I'm on it.
Yeah, now come posterior and get behind the greater
Oh,
trochanter.
yes. Oh,
Look
boy.
for some painful ones there. A couple a little higher, a little bit higher. Still going towards the greater trochanter. Looking around, looking around, looking around for some nice painful spots. And when you find a painful spot, you're gonna press on it. You're gonna like micro stretch it. You're gonna push out those painful sensitizing chemicals and let the blood supply with the good nutrients in it and good ATP and everything the muscle needs. So we're going all the way forward. The ones in the front, they turn your toes in, and the ones in the back, they turn your toes out.
Can I play dysfunction advocate for a minute?
You're
Can
okay.
you play dysfunctions advocate?
Okay.
Okay, I mean, come on, let's be realistic. I mean, so you do this, but isn't it going to be basically tight and sore again the next day? I mean, I feel like I could do this 10 times a
So,
day.
I
and,
have,
you know, it just come back.
So let's go over some of the underlying perpetuating factors.
Oh, that's what it is. Isn't it? They come
So-
back because
So what are some underlying perpetuating factors in gluteus minimus
if
here?
your glute region feels like somebody's beating you in your glutes, you know, in your rear end every day.
So what aggravates is leg length inequity,
Oh,
Morton's
yeah.
foot
And
syndrome,
Morton's foot, yep.
dysfunction of the sacroiliac joint could be a problem.
Yeah.
Standing still for too long periods, especially with your weight on one leg or your feet close together or with your toes turned out, you know, you could get into dysfunction with that.
Yeah, sure.
Sleeping on your back with your feet splayed outward, maybe with a heavy blanket causing it to
You
be.
mean sleep with my toes
Could-
out like
yeah,
this?
it could be.
Or
Then-
driving like that?
Well, yep, or driving like that. So whatever you do with your toes out.
Yes.
And so what happens is when you put those shoe inserts in to correct the Morton's foot, then you
Oh,
stop turning your foot out.
Yeah, when you walk, you're
And
not turning
almost
your foot out
immediately.
anymore. Yep.
Repetitive overuse of the glutes during sports, such as running and tennis, constantly with the toe out.
Yeah,
Okay?
I know, of
And-
course.
And
These are the
sometimes
ones I'm really thinking of.
injections in the buttocks can cause you to have a lot of trigger points in the buttocks. So
I gotta stop
So-
that.
Shooting yourself
Cut
in
that Just running out of veins in my arms, guys. Come on.
Yeah. So another test to see whether you have trigger points in the gluteus minimus would be also to do your knee to your armpit test with a little bit, but it also gets the other muscles a little bit more. Okay, so
All right, good. So yeah, that's the main thing. So obviously, most people are walking around with trigger points in this gluteal region,
well, you know, you can get them a lot from sitting on your butt.
but it's so common from the Morton's foot. It's just
Yeah.
so common from
Well,
the Morton's
Morton's
foot.
foot and sitting on your butt.
Yeah, exactly.
So here, now we're going to do the piriformis. So feel your sacrum, that bone that's above your tailbone, and you're going to roll to your outside hip bone, your greater trochanter, and then roll towards your sacrum.
Yeah, there's the
And then
piriformis.
roll towards your outer hip bone, and then roll towards your sacrum. Now look for a painful spot. So here, but this, you're kind of getting all your body weight right onto that one spot.
Yep.
For this, though, you have to be able to balance. You have to be athletic
Yeah.
enough to balance.
But you
on
can
the
do it
ball.
on the wall, and you can do
Yeah.
it seated.
Yeah, you can do it all those different ways or
Yeah.
laying in bed, but you
Yeah.
remember that was too soft, right,
Yeah.
Linda?
well, no, I just couldn't maneuver my body to get
To get
on
the spot you
Yeah.
wanted. See,
Yeah.
it's better to be standing
Piriformis,
or like this, yeah.
Comes down here, so we can. Why don't we just take a look at the referred
Yeah,
page
go ahead and look
for
there.
that? Where's the piriformis here?
Okay, now how about let's do, since we're gonna also, Justin, do the obturator internus trigger point. Okay, we're gonna do the obturator internus. So for that, you guys find the sit bone. So lean forward on the wall. Lean forward on the wall. Find your sit bone and go from your sit bone towards your tailbone. Go from your sit bone towards your tailbone, and then again out like this, because it goes all the way out a little bit lower than the piriformis.
So we did the gluteus
So
minimus
all
here.
the way towards the all the way out towards the
And then the piriformis right beneath that.
So
Okay, so you're
I'll come
covering
over there.
similar areas.
I'll show you how to do it.
It's falling.
So this
Well,
is
that
more
does
toward
that.
the front, and then along that middle ridge there. And then the piriformis is going to be deeper and a little bit lower, and it's at that angle right there.
Okay.
Get that origin insertion. The insertion's right under the sacrum. Get that insertion point, origin point, real well, and get that trochanter insertion right there. I mean, it really attaches right under the sacrum there. Okay, guys? It's a big one.
Okay.
And remember that the
So here we're gonna
that
go.
the sciatic nerve goes through about 40% of people. Goes right through that muscle. This actually causes real sciatica,
and
called
then-
piriformis
and
syndrome.
feel that sacrotuberous ligament right above. So right now we're going to look at the obturator internus,
Yeah.
which is right here. So you feel it. Here's your sit bone. It's between your sit bone and your tailbone there, and then on the other side of the sacrotuberous ligament, which is right here, it goes like this all the way over to just underneath the piriformis. So we're going to go like this.
So it's like a band across
Yeah, like
underneath
a
the piriformis.
That's right, exactly.
Yeah, so
Yeah, but it goes also into a little hole here. Let's look at it. I have a nice
see a picture of it,
I
yeah.
got it right here.
because here we have, you can see
Here's-
this right there, and then the piriformis
That's
right
it.
there.
And then here it
And the
is.
obturator internus.
Right here,
is-
here's the and then here's the obturator internus. You see, this is the sacrotuberous ligament right here, right here.
Yeah, right there.
Okay, right there. And so here's the obturator foramen, and there's the internus right there. It's going underneath the sacrotuberous ligament, and then out this way and all the way over here to the greater trochanter.
By the way, you want to know another home run? You can treat the sacrotuberous ligament.
Yes.
You can work on it.
Yes.
Because when that ligament gets sprained in some cases of like severe pelvis trauma or something like that, boy, oh boy, is that just a home run.
So we could do, so the way we would find it is we find the sit bone or the ischiotuberosity, and then we're going to go up there, right where it feels hard,
Yeah.
right where it feels hard, and go up towards the sacrum there.
Yeah.
And then that goes up and continues and becomes the longus in the iliocostalus.
And what kind of tool might you use for that? Might you use
I
a
think,
narrow tool?
well, I think I might use the
You
jackknamper.
might use the jackknamper, right?
Mm-hmm.
Yeah.
Yeah.
Jackknamper
So-
on a wall, maybe
yeah.
jackknamper on a floor or a
Yeah.
bed.
Mm-hmm. So, oh, you got me. How'd you know I wanted one? Okay, so for this, so we're gonna come. So here's the sit bone, right?
Yep.
Okay, so come up from there. That's the sacrotuberous ligament right there. So we could go right above it. So you could take your tool and get right on that sacrotuberous ligament.
Yep.
And you could treat that sacrotuberous right there.
Right on the wall. Yeah.
Right on the wall. Maybe, Justin, maybe you could see me better if I
Yeah.
was right here. And you could be right there. So here's your sit bone. Here's your sacrotuberous. And then you can get right on it like this.
Yep.
And press right on it. It's really good. Then move it up a little bit. And you're looking for a painful spot. If it was bothering you, you'd really feel it.
Yes.
You really feel painful. Okay, so that's a good. Now to do the internus, you want to go from. So you find the ischiotuberosity, come up, go inward right there. That's the part that's over the obturator foramen.
Yeah.
Okay, so we're getting right in there, and then you want to go on the other side of the sacrotuberous ligament.
Yep.
And then you're going to get right on that obturator internus.
Yeah,
Now,
it's just right. It's a band right beneath the piriformis.
now the funny thing, it feels really weird. It has a weird feeling. It really, that's why it's in this class, is because it gives you like a real weird feeling in the back of your thigh right here, and sometimes in your pelvic floor and your labia and stuff like that. You know, so
Do we have a picture of the referred pain?
I
For
couldn't
obturator.
find it for
Yeah,
some
I
reason.
know, I have.
I think it's described in her book, but I couldn't find it. I couldn't find a picture. But I felt it many times.
You
I
felt
know
it many
exactly
times.
what it feels like. Because it feels like really a deep, achy, it's like, but you feel it right here in the back of the thigh. And you think, and then you keep treating the back of the thigh, and it's not from there. It's from the obturator internus. Yeah.
This is where it shows up usually.
Externus.
This is internus.
Yeah.
That's why I was saying coccyx pain, and then right down here, that funny feeling down
That
the
funny
back of the
feeling,
thigh.
like yeah. So it gives you the really bad coccyx pain, but it also, what's interesting though is it gives you that really funny feeling down here.
Yep.
Oh yeah. So this is your tailbone pain.
Yeah, tailbone pain.
Mm-hmm.
So if you're having tailbone pain, look for that obturator internus and work on the sacrotuberous ligament, which kind of comes about a third of the way over.
So here it would be like, so it'd be right here. It'd be right where your sit bone is, and then it would go straight up like that.
Yep. Boom.
And then we're going to work this side over here to get the obturator internus, and then that
so that's
side.
the ligament she shows you. The sacrotuberous ligament goes
Like that,
right
and
like
so you're
that.
going to work on this side of the sacrotuberous ligament and on that side of it, and then it attaches over here.
Yeah, and then the piriformis sits right on top of
Just
that.
above it, yep.
Yep, and the ridge we were working on for the insertion points of the gluteus minimus right above that. So gluteus minimus we worked, then piriformis we worked, obturator internus we're working, okay? And that sacrotuberous ligament cuts it right there at about a third. So,
Yeah.
Yep, and don't forget, the gluteus minimus is causing the pseudosciatica, but the
Right.
piriformis muscle actually can pinch the sciatic nerve and actually cause real sciatic pain.
Oh yeah, oh it could,
Yeah,
it
yeah.
could really, and it causes all kinds of pelvic floor pain and dysfunction.
And this obturator internus, boy, you're getting the some pelvic pain too, I think, and also this, that coccyx pain. So, really
Okay,
important. People with coccyx pain get no relief from anyone. They go everywhere and nothing helps. So, especially if they had a bad fall, I had a bad sledding incident once, and that's what needed to be done. Sacrotuberous ligament work was really what needed to be done.
So we want to take a look at the semitendinosus,
Yes.
and we're going to look at the semimembranosus, okay?
Okay.
And we're going to take a look at the biceps femoris.
Why are we working? You're showing us all three at once?
Oh
We
no,
never do three
we're
muscles
gonna
at
do
once.
well.
Why?
Well,
Because they're all hamstrings.
because they all have the same test,
Yeah, they're all the same.
and they
test.
all have the same nerve roots.
Yeah,
Okay,
it's
except for the
hamstring.
biceps has S1 and S2,
Yeah, the biceps gets a little lower because it's
Yeah.
got that reflected.
but the
head.
rest of them have L4 to S3.
Oh, okay.
So, they're
Oh,
they're all included.
Yeah.
Okay, so L4 to S3 will catch them all. So also the S1 will catch the piriformis,
Yep.
and you'll see the obturator is L5 to S3.
Yep.
So let's take a look also at our nerve roots and see if we can't treat those.
Yeah. So these are our last muscles, and then we're going to do some nerve roots, and first I'm going to show you the strength testing again.
Great.
So that'd be great.
Okay, so again for the biceps we have some range of motion tests and
Yeah.
stuff like that. So for the all the
Hamstrings,
the hamstrings and the biceps femoris. So let's take a look at the tests. So it'd be 34, 36, and 37.
All right.
And
Oh, want to see the referred pain?
yeah, let's take a look at that.
I never use these charts, that's why.
I got it
There
right
they
here,
are.
Justin.
You got it too? Okay.
Here's
great.
in the book. Here's in the trigger point therapy for low back pain book, and here it is. So you'll see that so this causes really bad pain into the lower buttocks.
Oh, yeah.
So this is the semitendinosus and semimembranosus. So you see how they attach here on the tibia right there. So the semitendinosus and semimembranosus from the ischial tuberosity down to the medial tibia, and then here's the biceps femoris, and again it attaches here onto the femur and then also onto the ischial tuberosity, and then over here onto the tibia and the fibula.
Remember with
And look at the pain over here. So it's pain in the back of the knee and also on the back of the thigh. So they both cause back of the thigh, but this one's way high up makes you like your ischial tuberosity really
Yeah.
hurts.
Yep. Like something's pinching. It also often has like a pinching pain when you're sitting and stuff. And then so that's the medial hamstrings, the semimembranosus and tendinosus. And then the biceps femoris, which is the lateral hamstrings, gives you the really bad behind the knee and lateral knee pain. Now, don't forget, what areas are especially important to treat for hip muscles is don't just treat the trigger points in the belly. Make sure you use insertion and origin points. The attachment points are so important because, as we talked about with compaction injuries, so common in the hip, it's the GTOs, the Golgi tendon organs, at this, right where this muscle turns into tendon, where it becomes white right there. That's where the little GTO sits. And believe it or not, it just measures tension. And it's the reason you can't catch a kid falling out of a tree, because the tension that would increase so fast in your arms, or why you can't carry a kid in the front seat of a car. When too much tension happens too quickly, that shuts the muscle off and literally pushes the child out of your arms. Your arms will just open up so you can't catch or keep the kid safe. So that's why it's really important to use seatbelts. They don't have GTOs. And it's the same thing for compaction injuries. These little GTOs get super hyper active, and then they shut off all the muscles in the rest of the hip. So make sure you work at origin insertion. It's so important with the hamstrings. They get origin insertion injuries, so you really dig in at that ischial tuberosity. You really dig in behind the knee. It'll be really sore, and happens a lot.
So shall I show how we might treat
Yes.
the gluteus minimus, and then after that we could go ahead.
Self-care or
no,
treatment.
Treatment, yeah, and then how we might treat the piriformis and the obturator,
Yeah, before we get to the hamstrings.
and then we'll do the hamstrings.
Okay, great.
How's that sound?
Yeah. Well, what else do we need to do for hamstrings? Range of motion.
Oh,
Should we do that?
So the range of motion test?
Yeah,
We could
should
do them
we do
all. We do them all now? Yeah, we could do it.
Okay.
Yeah, let's do them. Okay, so let's do all the range of motion tests for them.
Yeah.
And so let's do so that would be 34, 36, 37.
Yep. And you guys know these already. You did probably learn some of these in school, right? This is the straight leg raise, right?
So this is touching your toes.
Yep.
This is bring your knee to your opposite armpit. And then here it's the leg lift. Yeah, straight leg lift.
You guys
So
know
so this would be, so we can touch our toes in different ways, we can lift the leg in different ways, and we can do this. This is a great test here. So let's do the knee to the armpit, 34, then we'll do 36, and then 37.
Great.
Okay, everybody could do that, get your measuring tapes out.
Great.
Okay, so let's take a look at
Well, how are we doing with toe touching? Should all try toe touching?
yeah, we can do it. Let's all touch toes.
No one fails that test, do they?
Oh, no, they never failed that test. Okay, so we're going to measure with the
Good.
International
Oh, I'm very proud
Myopain
of us.
Society.
I'm very proud of
Okay, let's
us.
see. Go ahead.
You know what this is?
Excellent. Okay, minus 1¼ inches.
You know what this is, guys? This is a sign that this is actually commonly
9
taught.
10 inches.
You don't get through PT or
Okay.
massage school or
Okay,
chiropractic
okay.
school without learning about tight hamstrings.
If you stretch them, they're tight.
Yeah, well, we could do more with it. Okay, great. So we can also do, what's another good test? We could have you do, let's
Behind the
have,
back and yeah.
let's one of you sit on my table.
yeah, it's so this is the one muscle they actually do cover pretty well, but the treatment of it not so.
Okay,
well.
who would like to sit on my table?
I'll sit,
Okay.
but not on a paper.
Okay, give me the paper clip back. Okay, so another way, put your feet here. Okay, so sit up for a moment. Yeah. So
Okay.
go ahead and let's go ahead and see if you can touch your toes. So this is this
Not
position.
this position.
Uh-huh. Yeah. So without gravity. Yeah.
Yeah.
Okay, so let's measure. Sure. Oh, let me have that tool. That tool. Yes, thank you. Okay. Okay, let's go ahead and let's measure. So here, bring your toe towards your foot. Okay, 4 inches. Okay.
It's not only just that
4
gravity
inches.
is at work. What's also happening right now? She's sitting, so a small hemipelvis or something wrong with the pelvis can cause her to be more tight in the seated position now too.
But anyway, it's good to check in this position too.
Yes.
So we
Oh,
can see
yeah.
other things are good.
Oh yeah, you have to check
Okay,
it in
so
all
let's
positions.
take a
Exactly.
also look at the and lay on your back. Okay, so we're going to check your hamstrings, and we can do that in a couple different ways.
Yeah.
But we can use this goniometer, could be useful.
it's just interesting that it's seated is different than standing. You know,
Oh, yeah.
it's
Yes.
important to
Yeah.
test in all its positions.
So here, you feel the resistance, and you stop about there.
Yeah.
Right.
And then you can see, you could measure from her heel to the table. So that would be one way of measuring, and then you could put down the measurement. So from heel to the table is 30.5 inches. But also, we could also do it this way. We could go with the right angle. So right at the greater trochanter, we're going to go put the one arm at 90 degrees and the other arm along her femur, and we could look at the angle, and we could see she's minus 10, 20 degrees. She's minus 20 degrees.
The idea is it should go to 90.
90,
so
correct.
she's measuring from 90 to
90.
where the leg is,
Yeah.
and that's her
So that's a good way.
net minus
so
number.
this side, how many inches was it?
30?
Yeah, I think it was. Yeah.
I think it's like 30.
Okay, so let's check the other side.
Okay.
Okay, so we'll see how many inches and what angle.
And even though the test says 90 degrees, I oftentimes would get
So
people,
it's right here.
I would get their knees almost up to their chest a lot of times. You know,
Oh yeah.
90 degrees is still, to me, not full function.
Okay, so this is 23.5 here. So we'd like to get it a little higher. And then we could look at the angle too on this side.
Yeah.
So here, you're gonna have one arm go straight up 90, and then this one's gonna go wherever the femur is, okay? And then you could measure how many degrees of dysfunction there is. Okay, or how many degrees less than 90. Okay, so you're gonna hold it right where I feel the resistance there, and that's about 22 degrees. So 22 degrees, so we'd like to get it to 90.
Yes.
Okay, so it's 22 degrees minus 90, from 90, okay?
Okay.
So that's the way we express it, you know. All right, so the next one is knee to the armpit test. Okay,
It
so
should.
we're going,
It really should. The ankle should just come straight up, nice and soft, and then have a nice soft end feel right there at 90
Right,
degrees
that's
or
right.
more.
so here, well, this is getting better. Okay, so we're gonna measure here, find the patella, the top part of the kneecap. You're gonna measure straight down to the chest, and here we go, straight down.
And you're going to
And then-
opposite armpit.
Yes, opposite, 9 inches, okay?
Yeah.
Okay.
And usually you're in pain if you're 12 inches, you know, so but 9, so it should just lay on your chest.
Yep.
It should, so we're here, so we're just gonna give it, here it stops right there, feel it?
Okay.
And I'm gonna go the patella, and we're gonna go down, and that's 10 1/4.
Okay.
Okay, 10 1/4 on this side,
Okay.
and 9 on this side.
Okay.
So we'll remember that, okay? See if we can get it better.
Yes, definitely.
Okay, let's have you turn to the side and go ahead and sit up and then stand up. Okay, so so that was the test. Now, should we do some treatment?
Yeah, we could do some treatment,
Yes,
or
uh-huh.
yeah, we could do muscle tests real quick if we wanted strength testing, or should we do treatment
Before?
first? Either way,
Before?
maybe before, because then we can
Yeah,
see how it changes.
Let's try it. Let's try it. Shall we try it? Let's try it.
Okay.
So let's try it, and then we'll treat different things.
Yeah.
Okay.
Okay.
All right. So let's try. We're gonna do the strength test. We looked at the range of motion
Okay,
tests.
strength test. Let's see which ones.
So we're gonna do you want to do glute medius?
Yeah.
Okay.
So glute medius and minimus, kind of hard to differentiate. So I'm going to show you. I'm going to cover TFL. So remember, we want to straighten the muscle. So the TFL comes like this. So to get it straight, we turn in like that. So that it straightens out like that. And I bring it out at 30 degrees up like this. And then I ask her to push up and out at that 30-degree angle. Push up and out into my hand. Push. And easily collapses, okay?
Well, it's kind of easily.
Yes, so she should push up and out, and I should be able to add 1, add 2, nothing.
No,
Okay.
no, we're not doing that.
Try the other side for TFL. Push up and out on this side, and I add 1, 2, 3. Okay, so that side,
That was strong.
yeah.
So the
Okay.
right side was strong, the left side was weak.
Yeah, now for glute medius and minimus more, we do down 30 degrees. And I have the heel turned out like this, okay? Because that is coming this way, right? So to get it straight, I turn it out like that, okay? So push down and out at an angle. Push down and out. Nothing. no
Weak.
ability to contract
That was
at
weak.
all.
That
Yeah.
was weak.
Now we try this side. Push down and out. that angle.
I can't
Push down
even-
and out, push down and out.
I can't even hold
Try.
it.
1, 2, no, nothing. Okay, so gluteus medius and minimus, no good at all, right?
Right.
So, okay, now, we did the,
We just did the obturator internus, and then we just did the hamstrings.
well, the obturator internus is a very interesting test. Maybe I'll show it to you guys.
Okay, that'll be fun.
Yeah, you kind of have to be lying on your stomach. Here, I'll do this one. Here. This is a general external rotator test. I'm not going to show you. That one's really hard to learn. But undifferentiated. This is all the external rotators with the knee at 90. Turn like this. Keep that right there. Hold that up. I'm going to pull this way. Okay?
Yep.
Directly parallel to the floor. So you keep your ankle toward that window. I'm going to push. 1. No, go ahead. Keep pushing. 1, 2. Don't let go until I'm done. 1, 2, 3. So it's not weak if the patient lets go. If the patient lets go, that's just not a test. You have to keep contracting as long until I'll say done.
She's trying.
No,
She's
no,
trying.
no. Push that way. And then I add 1.
I'm trying.
Okay. Push. 1.
It's hard to
2.
believe.
Okay. She's letting go. So that's when they let go, that's not a weak test. That's just we'll have to get some other reasons for that. Okay. Push that way, and I add. I didn't even add yet, and you moved your foot out. See, if they move their foot out and you didn't push yet, the patient is trying very hard to do something. All right, push that way. Okay, 1. Okay, well, that's weak. We'll maybe find someone who's strong there.
Okay, good.
Okay,
That's
and the
super.
hamstrings. Okay, with the heel perfectly neutral. That's just the general hamstring group.
Right.
So pull back as I pull. So that would be all the biceps. Good. Femoris and the
Semitendinosus and membranosus.
Exactly. What about if I were to turn out this? If I turn the foot in, what do you think that straightens out? And I were to pull out at this
I
angle.
think you're yeah.
Right. I'm getting the medial hamstrings by pull. Okay. Ready? 1. Okay. Good.
And let's
and
get
then
the
turn out. Yeah.
lateral hamstrings.
Exactly.
The
Pull back
biceps.
the heel. And 1, 2, 3. Good. Okay. Good. Those were better last time. Remember, they were terrible.
Right.
So it's gotten better. Okay, knee straight. Hamstrings both sides. Pull back. And then I add 1, 2. Nothing on this side. We're having trouble on this side, aren't we?
We
So far,
are.
has anything tested strong? On this side, nothing yet, right?
Nothing's
oh,
strong.
gee, what are we thinking?
Could be.
Compaction. When everything's testing weak, okay, turn the foot in and keep the heel back.
Hi
Side pull.
there.
1, nothing. And
This
how about
knee
out?
hit the dashboard harder in my car accident.
Yeah.
Yeah.
How long ago was the car accident?
About 13 weeks.
Well, if
Yeah.
the knee hits the dashboard, this is my knee, then
It compacts.
it would cause that compaction, right?
They both hit, but this one harder.
Oh,
So-
jeez.
Mhm.
Okay, and pull back this side. Okay. Try again. Hold.
It's hard to believe.
I think it's this. Okay, it's not fun to contract that, but I think we found the one muscle that is hypercontracted. Remember, in a compaction injury, joint gets compacted. One muscle has crazy Golgi tendon organs causing all the other muscles to shut off, and that one muscle fires. Should we test just a few other muscles on that side to see?
Well, look, I don't think we should. Let's
let's
do
just-
some other things first.
Yeah.
Yeah.
Push. Let's just try. Yeah. So there's nothing going on this side at all. So we got lucky. So we will want to treat what the origin and insertion of the
Gluteus.
biceps femoris.
Yeah.
That
Oh.
should turn the entire hip back on.
Oh.
Also, the other quick
No,
test
why
for
did you
hip
pick? Why
compaction,
did you pick biceps femoris?
because it's the one test that tested strong.
Oh. Okay.
The one
yes,
muscle
yeah.
that was.
The one muscle tested
One
strong.
muscle was
Yeah.
strong.
And the other way to prove it's a compaction is you just cause a little bit of distraction, pull at the hip, and then let's come back and let's test our TFL again, for example. Push up and out. See? 1. Yeah. She's getting a lot of cramping. And where are you getting your cramping?
Right in,
In the lateral hamstring, right? In the biceps femoris. So whenever she's contracting anything, remember I said no muscles will contract except for one? Everything she's doing, she's trying to use her lateral hamstring to do it. So it's cramping all the time. And that's, I think, why she was giving up on some of those tests. So the lateral hamstring is hypercontracted. The Golgi tendon organs at the origin and insertion are causing the entire rest of the hip to fire, not fire.
And then when you're asking her to contract more, she cramps.
Yeah, she cramps because she keeps trying to use everything. I use TFL, she's trying to use the lateral hamstring. Every test, she's trying to use the lateral hamstring because it's the only one firing. Okay? Good. So water intake and treat the origin and insertion of the lateral hamstring, biceps femoris, which is good. Good segue to treatment. That's why I wanted to do these tests first.
Okay.
Here we go.
Yeah. All right, treatment
so
time.
We're gonna do a little treatment.
Sure.
Okay. Okay. So let's take a look at treating the hamstrings.
Okay.
Okay. So if we can have you go ahead and lay on your tummy.
And then
So we're
did
gonna
we
give
do
you
self-care
change
for hamstrings too? We didn't do that yet,
Well,
right?
we could do the hamstring self-care after.
Right. Sure.
Okay.
Good.
Let's have you come up on your hands and knees for a minute.
Well, thanks for being such an interesting case. I mean, it's amazing.
We never disappoint.
You had hip compaction that first time,
Yes.
but it was the one muscle we didn't treat. It was glute medius, which was on next week's test. She actually has a hip compaction with the exact muscle for this week.
Aren't we considerate?
Yes, you're so considerate to have the conditions that we're working on. Thank you.
So we're going to take a look at the ischial tuberosity. So we're going to go ahead and find it. We're going to press on it and go up towards ischial tuberosity and go a little bit to, let's come around it and come up medially, and let's come around and let's go up laterally and get right on that ischial.
Yep,
Let's
that's
come
that
on
insertion
down.
point.
So here we go. So we're going to come straight down, sort of between the femorises and the semitendinoses, kind of in between the two. And then we'll go to either side. And here I find some taut bands.
Oh yeah.
I got a few taut bands
Yeah.
here.
yeah.
Now this muscle here is called the chair seat victim.
Yeah.
Okay, this group of muscles.
We didn't name it that. Our names are cooler. Chair seat
Travell.
victim.
Travell.
That's a Travell.
Travell's name. Yes.
Chair seat
Travell
victim.
called it the chair seat victim.
Yeah.
So what happens? But it's even more true now than in
Yeah.
Travell's time because everybody's sitting.
Yes.
So the chair hits you about right there.
Yes.
And that's where all the trigger points are.
Yeah.
And then this is going to give you back of the knee pain and pain at the buttocks
Yeah.
and the whole back of the thigh.
Yeah, because remember, if we look at these hamstrings, we have the medial ones go right up into the buttocks and back of the thigh, right over that insertion point at the sit bone. And then the lateral ones cause pain down by the knee, right there. Okay? And again, we were really lucky to have a compaction where this lateral one, the biceps femoris, at the had injuries here, the Golgi tendon organ here, and the Golgi tendon organ here will be really tight, shutting off all the other muscles in the entire hip. So again, that was really neat.
So here for the fastest, for the biceps femoris, we're going to find again the outside of the ischial tuberosity, the sit bone. Then we're going to come lateral
Yep.
out to the outside, and we're going to come right here on the outside of the femur,
Yeah.
pressing right onto the biceps. Now to stretch it a little bit, we're going to pull it a little bit to the outside, to the inside of it, like there. So I'm stretching it a little bit. So I just feel the end point right there. So I'm just giving it a little stretch. So I'm treating it while I'm stretching it. And this coming down all the way to the lateral tibia. Here we go.
That's too much.
Here we go.
Too much for her. So you're turning your ankle in, or you're
No.
you're just stretching it. You're
Yeah, just putting it a little bit on the stretch. Yeah. There. So here we go into the attachment. It starts to let go a little bit more down here.
Yeah. This
And
is
it's
the
gonna go
part that
down.
most people miss because it
Going
feels
to come all
awkward.
the way down here to its attachment onto the tibia.
Yep, that's exactly right. Don't forget, its insertion crosses the knee joint as it's down on the tibia.
Mm-hmm.
So
Comes all the way to here.
Yep.
Okay, so now we're going to take a look at the attachment again of the semitendinosus and semimembranosus,
Yeah.
okay?
Yep.
And then they come down and attach over here on the pis insurinus,
Yep.
okay? So here we're going to go right here, so we're going to treat it a little bit while we're stretching it. There.
I would say my experience with hamstrings most people treat them, but they miss the origins and insertions,
Oh.
and that's a big miss.
So this is where the neuromuscular juncture would be.
Yeah.
So this is
Right.
usually where the referred pain would be to the butt.
Yeah,
To
yeah.
so this would cause referred pain right here. So to give you kind of like part of the sciatica.
Right. Whereas the ones in the lateral would give you
Pain
here.
about right here. Yeah.
Yeah, exactly.
So here we're coming on down. So give it a little stretch.
And classic sciatica would go down
Oh, it
like
would.
this.
So that could be
It
part of
would,
sciatica.
It would.
And it could be a satellite activation from the piriformis and the gluteus minimus. Could be.
She's rotating the
Mhm.
thigh more than the knee, right?
Mm-hmm. And we're coming here to its attachment. Yeah.
Yep.
Yeah, we're giving it a little bit of a stretch.
And those
Okay.
attachment points can be killer
No,
sore.
Let's give it a little
Those are
massage.
incredible, right? Yeah.
Okay, so let's take a look on this side. So here we could do it a little different way. We could stretch it a little bit. So let's take the center, and we're going to give it a little stretch this way. So we're going to start the ischial tuberosity. We're going to come in, touch it, and then come towards it and get underneath it and get right onto the attachments. And get right onto those attachments right there. And right onto the attachment. And then let's go straight in. Now here I find a little bit of a taut band. What do you think?
Oh, yeah.
She notices a taut band there. So when you're doing the treatment, you're evaluating for the micro dysfunctions. So when you're giving the range of motion tests or the strength test, you're looking for for the whole muscle working together. But here you're feeling the taut bands individually.
Yes, exactly.
Yeah.
The only way
Groups of
to
taut
test
bands.
full range of motion is to include palpation, because
Mhm.
full range of
Right.
motion means each individual band has full range of motion.
And little groups of bands. Yeah.
And now you're separating the bands rather than
Well,
as
so
a
much
whole.
more. We could be separating the bands. I wasn't trying to separate them especially, but probably we're separating them a little bit there. But the thing that I'm doing is pressing on the
I mean, I didn't mean the bands. I mean the muscles. You're
Mhm.
isolating
so we're
the individual muscles.
what we're
rather
going to do is press on the muscle and find, so right at the neuromuscular juncture, we're going to press on it, and then we're displacing the painful chemicals, and when we lift up, then the blood supply comes in. So we're right into the belly of the muscle, right at the nerve muscle juncture, and we're reconnecting the nerve muscle juncture to the nervous system. And it's all filled with the painful chemicals. It's not really communicating in the same way as it was, without the painful chemicals. So it's like pickled in them. And so if we push them out, now it has full communication with the muscle. The nerve, when it tells the muscle to contract, it contracts. So here we are coming all the way to the outside. So different techniques I like to use. I like to use my knuckles like this. When I do that, you'll see that I work straight through, and I would push from my feet right into the knuckle. Mhm. Now the thing is you could use your elbow in many places, and that's a good way too. So coming through here, and I feel some taut bands right there. What do you think of those?
They're painful.
She notices those. And we're going to come down all to the attachments over here onto the fibula and the tibia.
There's a trick when you're working on Golgi tendon organs. They say to take the tension off of the Golgi tendon organ so it resets. You can push up and in, so like this. You push like that. Straight compression is good, of course, but if you compress the Golgi tendon organ up and in, and then that would be opposite at the origin insertion. You push down and in. You see, toward the belly. Toward the belly of the muscle pressure is what takes all the weight off that Golgi tendon organ for a second. And so
up and in and down and in.
Yeah,
towards the belly of the muscle.
yeah, for the Golgi tendon organ. But Sharon is doing all planes. I mean, she's doing toward the belly, out toward the belly, laterally twisting sometimes. Fascia can get adhered on the rotational plane, right?
Yeah.
So
Well, this is a good stretch for the vastus. I mean, for well, actually, you do get the vastus a little bit there, but for the femoris.
Just out of curiosity, was it more tender at this insertion point?
It was
or
pretty
was it more
tender there.
tender at this insertion point?
No, the lower one.
The lower one, right?
Yeah,
Yes,
yeah,
that's
the lower
very
was.
typical.
Yeah.
It's these
Yeah.
insertions of the hamstrings get missed because they're so tender, nobody likes to touch them, and people think of the hamstring as here. They don't realize it's crossing the knee. It's all the way down to here. You know, it gets missed a lot.
Now, the gluteus maximus and the gluteus medius, minimus, and piriformis and the obturator internus and externus will all be here.
Yeah.
So let's take a look at treating. So if we were treating the gluteus medius, we'd be like we feel the top of the ilium, we come down and press up, but we're not. We're gonna treat the gluteus minimus, so we're gonna feel the greater trochanter, the hip bone right there. Come away from it, come down and towards the greater towards the greater trochanter here.
Yeah.
What do you think of that?
That's a good spot.
She's thinking good.
I was working on that.
She's thinking good.
Do we know much about your water consumption? Are you keep hydrated?
Yeah.
Okay, good.
So that's good. You're going to come in through here and treat that. You can also come. I'd like to go ahead and you'll see that in the book too. We can go ahead and stretch it a little bit, the gluteus maximus,
There you go.
and we come like this and get right onto the attachments of the glute max.
Yep.
Now here we have the here's our sit bone.
Ischial tuberosity.
Yes, our ischial tuberosity, and then here
I know
is
it well.
here's our, you can sort of feel this is the sacrotuberous ligament. And so if you come this side of it right here, you're getting onto the obturator internus. And then if you get on the other side of it, you're also on the obturator internus. And then you're going to go ahead and look at that all the way to the outside of the hip bone here, the greater trochanter.
Yeah, and it was angled this way before, but as she's brought the hip up, now it's like that, so it's really
You can
accessible.
get it nice. Okay. Now our piriformis is a little bit more higher here, and it's going to go underneath the sacrum. So that's where it is there. And this would be an okay way to treat it as well.
Very common. The most common cause for hip compaction is the Golgi tendon organs of the piriformis. And so, again, you would work
So
down
here-
and in, and
So
down
here's our
and in.
attachment here,
Yeah.
and we're going towards the middle of the muscle.
Yep.
And here would be its attachment here. They'd be going towards.
Yeah.
This attaches kind of underneath the sacrum.
And that's for the Golgi tendon organ. Of course, you know, Sharon will have you push in all directions.
Okay, so we took a look at our muscles here in the hip.
Yep.
And then we also saw how to do the self-care on this, but we didn't see how to do the self-care on the hamstring.
Yeah, let's see how self-care has to
And-
because how do you get this? I've
Yeah.
never, how do you get this area with self-care with the hamstrings? I'm really curious.
Let's
to
try
see.
this. Let's try this. So let's have you come up onto your hands and knees, and let's see if we can treat our hamstrings.
Alright.
So we'll have you. Would you like to sit with your legs out in front of you? Sure. And we're going to use a stretching strap.
And then we'll take a quick break. So let's do this for 5 minutes, and we'll take a break. And we'll come back.
Okay. So just holding that together. Okay. So here we go, and you're going to hold on to that. And I like a couple different ways of doing it. One way, I like using the back knobber here like this, and so you go ahead and put it. So you'd have to like like that. Yeah. So you get underneath. And you go all the way. Let's get over here. Let's get at this attachment over here. So you can come like that and get right onto it.
It's pretty
So you can
coordinated.
reach right there. Get right to its attachments. On the semitendinosus and semimembranosus. And coming to its attachment over here on the pes anserinus. Okay, so you can get that way. You can come this way and treat it this way. Tar baby. Okay. So you can come in kind of like that. Okay. So you press in and come like this. So this is a good way of getting underneath like this, and you're stretching it at the same time. Sometimes you don't have to use a stretching strap. You know, you could just use 2 hands like that. Stretch it later. Now, you might want to put your back against the wall.
Right, yeah, because I'm kind of falling
So we're
backwards.
demonstrating how you might do it. Okay, so this is a great way to get so you can go from this side and get onto that side right there. You kind of press your leg down, and you come in through here, getting through here, and then you're going to go all the way up to the ischial tuberosity, all the way up there. Yep, and you're going to come like that. Yeah, just like that. So that's a good way. Okay. So you I treated one leg, you treated the other. No, we both treated the same leg.
Right.
Okay. All right. So try it on that leg.
This is when it needs it. Maybe use the jackknobber on that side. Want to show her how to use the
Go ahead and
jackknobber?
try the jackknobber on that side. Try this one. So you're going to go back. So go behind the knee here, and you're going to press. Now what you want to do is lean towards the leg you're treating. Okay, come like that, and then lift up, and then you're going to come, get right there, and lean towards the leg you're treating. Okay, you're going to come up higher, keep coming towards the ischial tuberosity. Okay, you take it up higher. Okay, so now you're going to come on, you want to go down the outside and towards the tibia and the fibula. Okay, now I'm going to show you another way of doing it while you're doing that. A good way to treat the hamstrings is you can put your leg up on, so you can decide how high you want it. Okay, so okay, you can get your hamstrings up on the table, and then you could go like this and treat your hamstrings like this, and you could feel like get right onto the taut band. They feel, oh, I can feel the taut band there, and then you go like this and you kind of fold, and notice what spot you press on allows you to fold. Just like here. So if you get right onto the attachment there, so you kind of and you want to fold right at the hip here. So you're trying to fold and get closer and closer, and feel what spot is causing you not to be able to fold all the way. So then again, you can do both sides. So here you're going to go, I got to get right onto the attachment on the lateral side on the biceps femoris. And again, I can feel the biceps there, and I press towards it, and then lean and really fold. And that gets our hamstrings really good. Yeah. So and then you go all the way up to the ischial tuberosity.
The folding puts stretch into the hamstring.
So okay, the thing is if you don't fold with a flat back, so if you notice me, I'm folding with a flat back, that gets your hamstrings. If you fold with a round back, that gets your back muscles more.
Yep.
But if you want to really get your hamstrings, you just think fold right there, fold, and then when you're stretching, you just fold right there.
Yeah, I like to think chest to knee rather than head to knee.
Yeah.
Because if you do head to knee, then you're round.
Yes.
Chest,
Yes.
Yeah,
Good.
exactly.
chest
Another
to
tip.
knee
Yeah. Good.
gets it.
Okay, so we found a couple ways of treating the hamstrings.
And
Okay.
just as a tip, when you're doing Golgi tendon organs, it's not as necessary to have it on the stretch. You can do it. She could just bring this knee so the foot's flat, and then she could actually just push in with her thumbs, like up and in. That would be a medial insertion. Okay, right there. Yeah. Or she can come on to the other side. Why don't you bring your knee up, and then why don't you bring your hands over.
How about this?
Yep, you could do that, and you come up and towards. Yep.
Up and toward.
Yep. For most trigger points, you want them on the stretch a lot, but for the GTO to reset, it's okay. We're trying to take the tension off of it. So it's okay. Sometimes it's easier. In the hamstring, it's the case. It's almost easier to get it with the knee up like that. Yeah, it's great. And do this side too. Really, really get this insertion point where it was really sore, and then we had that whole hip was shut off from that point. Let's say up in here. It's inserting right in there. Got that there?
It'll be on the tibia and the fibula.
Yeah, exactly. Is it sore? getting better?
Yeah, I'm not feeling it as much.
Good. Excellent. Okay. Should we retest you real quick on the hip
Sure.
compaction, and then we'll just see, and then we'll take a
Yes.
break, and we'll come back for some other cool stuff. We'll look at the nerve roots.
Yes, we'll take a look at the nerve roots.
Okay, so everything was weak except for the lateral hamstring, and whenever she contracted anything, that lateral hamstring seemed to seize up. So let's try TFL now. Push up and out. Oh, good. Still cramping in
Still
there, right?
cramping in here.
Yeah. So it needs more work, but it's strong now. How about down and out? Oh, you see how she just moved right away? The whole leg just swung right out. And we did this quadricep. Push back into my hand. Good. Okay, and then we did the hamstring, the medial one. Ready?
Which way am I
So
going?
pull back at the heel, yes.
Oh, just
Yep.
right there.
Pull back. 1, 2. Nah, see, we still have too much hamstring problems. Pull back. Okay, and what does that mean? That now, actually one way you can test is you can go over the origin insertion points, just give them a little massage to kind of activate and see if that helps more. Pull back.
That's a test.
Pull back, it's a test. Nothing. Okay. What if you went back to the nerve root and you just massaged a little bit, kind of activated some of the
give us
nerves right around L4 through S1? Huh? What if I just did that? Oh, yeah, you feel
Even
that?
L5.
Yeah,
L5,
L4,
L4,
S1.
S1.
And then if I did that, pull back. And that's it. So,
That's
Nerve roots.
so now we have nerve roots. Yeah, that's another way. But we're going to use our
We're
what
going to do skin rolling.
What do you call the? What do they call those EMGs? Oh, finger,
EMG.
finger, yeah, finger MGs, finger MGs.
That's
We'll do,
it.
yeah, we'll do that, and that's because that's what's causing that hamstring still not
Yeah.
to get. It's not getting its nerve supply.
yeah.
Okay, so let's take a look at that.
Okay, should we take a break first?
Oh yeah,
since they
well,
haven't had a
let's
break
let's
and
do
we've been
that.
rolling?
We're gonna take
Take
a break.
first.
All right,
We're
Was
gonna
L4
take.
and
She's
what?
taking a break already.
activated
Good night.
L4 through S1. Okay, break. We'll be back at 12 to the hour. No, 7 to the hour. 7 to the hour. So 53. Right? Okay.
Drink more water. Good.
What's the class last week? But they all had that other problems. They all, like, one had a stroke, one had a nervous, like, degenerative disease. Is that something where
They might have muscle
they might have both
dysfunction
too?
Yeah,
Yeah.
they definitely.
Yeah,
Yeah. So like treatment would help them probably.
most likely.
Most likely. That's why.
Yeah,
I
that could be.
didn't want to like push them very hard. You know, like is that the dealing with this stuff? They get
Muscles cause so much pain.
So much.
Really? I mean, they're always one of the most painful things in your body.
always thought they did it for myself, because I always think part of it. Like, he does some things with, like, what was it? Fast pictures.
Yeah. I'll just get so many. Yeah. MS I helped a lot of people with MS. They had major myofascial as well.
Yeah, it seems like it kind of leads to that.
Yeah, but then I trained them to be a therapist, and then I trained them to exercise. They had to do exercise all the time. They had to change their career
Yeah.
and be an exercise therapist. So I trained them to be an exercise therapist. And they started doing water therapy and stuff like that. So they did that all the time. They could do that. They were in bed with they were in bed with MS. But MS, I think, is it definitely many things.
Okay, so it's something dealing with experimentation stuff.
I couldn't find it. I couldn't find it. This is me. I got my name on it. This is
That's good. This is the Japanese.
my Japanese rest.
Oh.
So I did something really strange
Yeah.
to my wrist because I was feeling this weird sensation. And I don't think it's carpal tunnel, but I was feeling this, like right there, kind of like a nervy kind of sensation. Not really painful, but almost like electrical. So I started working on all the trigger points and here, good. Now my hand feels worse.
Yeah. Yeah, maybe you'll find the part. Okay, so one of the muscles that can cause the pain there is this one. This is the,
Yeah.
this one here. You're not passing the range of motion. See? So it should easily come to this finger. It's not coming out, right? Yeah. So if your finger's flat, it's not getting to there. So you know it's dysfunctional. See? And it has nerve that goes through it. And guess where it causes pain? Here.
That's
So sure.
Yes, see?
How much left to do?
Yeah. I thought I'd show how I do different things.
Good.
Yeah.
Got some ideas. I guess we could. Maybe we could do some graduate lectures or something.
Well, we could, yeah.
Whatever you feel like doing. Whatever you think extra tips we could get.
Okay, look, it's coming over there. Coming over there pretty good. But you want to get that, then you got another nerve running from here. So this one here. This is I fix people's hands during dinner. So if someone's serving us, then I fix people's hands. Right during dinner. That's illegal.
Just what do you think that is? It looks like some displaced fascia. Dislocated it. Never kind of got back over so far the knuckle.
Okay, so you want to get this behind your palm. So you want to be able to get your thumb and let it stay there behind your palm.
You know,
Like
every
this.
day.
Not that way.
Sore?
Not that way.
No, I got my
Oh,
wrinkles
this
back
way.
too. It like
That
Mine
means
is thick.
this is the,
Yeah.
and that's this
Thick
one.
is-
Being stretched.
spiny there, yeah.
Yeah. That's one way of saying it. It's painful.
That's the,
I mean, I can straighten that.
Yeah.
Like 99% maybe. But at first it was like, yeah, you know.
If it's painful, then you know the nerves are sending information into your central nervous system that there's a problem.
Yeah,
You'd like no one to be
yeah,
reporting
but
problems.
really, you have to break through it.
Yeah.
And all of a sudden,
Yeah, it eventually will stop. It's
I
like
don't think I've ever had this one.
yeah. So,
After doing yours.
yeah, well, this is, yeah, we've been doing so many years. And then, yeah, so now we gotta fix everything. So you wanna get this thumb way behind your palm. So you need to see there.
I'm glad that you're taking
No,
it.
it's just I see so many body workers, no matter how much experience they've had, when they see the amount of confidence that Sharon goes at a joint, she goes at it with this confidence because she knows that it's supposed to do that, and she's not afraid. The pain doesn't scare her because
It scares me.
Yeah, it does.
I mean, I've worked on
It's
clients, but I've never,
They don't teach you that it's okay to go through the pain. When you know the function and you're going for it, it's okay to do it.
and you're going to stop when you're doing it.
You will usually.
It's hard. Oh, not me.
Yeah.
Well, we know you'll never stop.
You definitely need to get.
I mean,
You can break through
I go
that.
like, oh, this is so painful. Oh, I can't believe it. Painful. This is, oh my God.
You can get through it. You can get through it.
Okay, move that around, see what you're thinking.
Yeah, that's
How's this different
a
thing?
sign of a good treatment. You're glad it's over.
I still have a little bit of that sensation, but not as much.
Yes.
It's a very nervy sensation.
Yeah. So you can do the carpal tunnel like that. So here's the carpal.
Yeah, it's more of a sense. My nervy sensation. So sort of, yeah, more down.
Jiu-jitsu artists or something.
He's got such strange problems. I got my share.
Just the last 2 weeks, not too excited. Okie dokie. It's time to get started again.
Japanese.
Oh, this is Japanese.
Yeah.
That was Japanese.
Okay.
All right.
So Justin,
Yeah.
we were just going over. So a lot of my massage therapists, if I go to a conference of any kind, I might fix 20 or 30 massage therapists' thumbs in a row.
Yeah.
But you gotta. What you want to do as a goal is getting the thumb to be behind the palm, and it's almost there, but it's not quite there. But you want to get a little further back, and that would be treating this opponent's pollicis. So you want to be able to pass that test. You want to be able to get this finger to go all the way to the baby finger easily. You want the baby finger to come to this index finger easily. So you want to get you to pass all those range of motion tests. Yeah.
So is being a body worker a perpetuating factor? Is that what you're saying?
Yes.
No, I wouldn't say that. Actually, I think treating people is good for me, and
Yeah.
it's good for my bones. It's good for all my. So I'm not finding it's really, but life is like that. So you want to be able to get. So this is a pass. You want to get your thumb behind your palm.
Uh-huh.
You want your first finger to come to your baby finger. You want your baby finger to come to your index. You want to be able to pass. You want to extend your fingers and bend all the interphalangeal joints like that. So you want to be able to get your hands to be able to work.
Yeah.
Okay. All right. Next we're on to back of the thigh pain. Oh, guess what are we doing? Hand pain.
I don't know. What are we doing, head pain?
The last one is going to be the lesser finger, so it's going to be March 7th.
Oh yeah.
And the just before that will be the rest of the fingers. Okay. Okay. So we did. So we took a look at a lot of the muscles, didn't we?
Yeah. Yep.
So we took a look at the internal obturator internus, and then the piriformis. We looked at but what we didn't do, we did the hamstrings. We didn't do the nerve roots.
Yep.
Okay.
Nerve roots.
Let's take a look at the nerve roots. Okay. So we'll do L4 all the way to S3. Okay.
And our victim of choice for the week, who demonstrated the most interesting case, was she had a left hip compaction with hypercontraction of the left biceps femoris.
Can we take off your shirt? We want to look at your. We're going to look at your skin.
Look at my skin.
And we treated the origin insertion of the left biceps femoris, and it turned on all the muscles of the left hip except the hamstrings again. And then we just stimulated the nerves that supply the hamstrings, and it caused an increase in your strength. So that is a good sign that we are going to find some nerve.
So we have some nerve issues here. This is about L4. Okay, here we go, L3.
Yep, finger
Okay.
EMGs.
And then
finger
here
EMGs.
L4,
Ooh,
L5. So
ooh,
here we
look
can't
at
lift
that.
up anywhere in here.
Oh.
So and let's go down to the S's. So we're kind of tight in the S's too. So let's hear. So it's showing a hypertone, in especially that side.
Are you guys
this
using
side?
this, practitioners?
Mhm.
Every person this week who comes in,
Okay, so here
roll the spine and see if you find anything.
L3, L4 here. Okay.
Yeah.
And all the way. So this is definitely bothering her.
Is
so
it
I'd
worse
say,
on one side?
Yeah, this side's
Yeah.
worse.
Yep.
Okay.
The side
okay.
that has the bad hamstring is worse.
Mhm.
Yep.
Yes, that's worse here.
Mhm.
Okay, so let's take a look at treating it a couple different ways.
Yeah.
Okay? So one way of treating it is you could have them lean over something. So you could lean at home. You could lean over a countertop. How comfortable is your head?
Oh, this is nice.
She's good. Okay, so here, let's look. We feel here. Let's feel the spine. So here's the spine. Ooh, we can feel some really taut bands right here, right along the spine, in the rotatories and the multifidus. I can feel it right there. And also, you can feel some here in the longissimus iliocostalis, right here. Okay, so and we'll look over here into this the sacral multifidi and rotatories. So let's go ahead. We'll start on the right side, and let's feel the spine with our elbow. And with the spinous process, let's go a little bit medial, lateral, and then we're going to press medial here. So we're going to press medially into the attachment, to the multifidi and the rotatories, down into the belly of the muscle, and over to its attachment, down onto the transverse process. And then we're going to lift up slowly, and then we're going to come down a little bit more inferior. Again, we'll feel the spinous process. We're going to come over here, and we're pressing in towards the spinous process first, and they're kind of rocking, and then down and towards the attachment, and then we're going to come up slowly. So here we coming up now again. We come feel the spinous process. We're going to come down, in and towards the spinous process, the belly, and towards the transverse process and the other attachment. So again, a little bit lower. So I find some little dysfunction right here. So I'm going to press towards the dysfunction, and then press towards the belly and towards the transverse. And then let's come down here. I can feel some right here. So I feel it. So you can feel that right in there. I'm going to go right onto it. We're pressing out all the painful sensitizing chemicals, Justin.
Oh, that's nice.
And we're going to then
Like substance
passively
P.
the blood. Yeah, substance P is one of them.
P for pain.
P for pain, substance P. So we'll get rid of that. So here's the spinous process again. Pressing in towards the spinous process, and away and down towards the transverse process and the attachment. Now we're going to keep coming down. Here I find some interesting dysfunction right here, and she notices it too. Okay, so we're going to press in and towards and away.
Now, what other muscles might contribute to some compression in the lumbar spine that would cause some nerve irritation? Not
What
just
other nerves
not just the tiny muscles.
no, not these tiny ones.
No, there's some big ones.
could be the longissimus,
Yeah, the big
iliocostalis.
Oh yeah.
But also our QLs on both sides could be
QLs
pulling
on
down.
both sides, absolutely. They can compress down on one side and cause a problem if your nerve roots, with the nerve roots there. And the psoas,
What if the psoas was pulling forward into the lateral and pulling on discs and things like that? So it could definitely cause trouble.
Yep.
Okay, so here we are into the S's here. We're into the S's. And the S's would go to that obturator and to most of the muscles we were working on today.
And is this giving a little bit of a stretch to the intrinsic muscles a little bit?
We are stretching it a little because, see, when we go like this, we're stretching and we're pulling the vertebrae apart. So we're stretching them a little bit while we're doing it.
It's better than just lying prone.
Yeah.
Yeah.
So the gluteus minimus went into the S1. The semitendinosus went to the S1, 2, and 3.
Oh yeah.
All the hamstrings 1, 2, and 3, and the biceps femoris was S1 and 2. Piriformis was S1, and obturator is also all three S1, 2, and 3. So that's hitting a lot of the muscles we were working on today.
Do you ever work on it with rotation too?
Yes, it's a good way. Well, first time I usually do it this way, and let's do it with a little bit of rotation next. So let's have you go ahead and just rotate a little bit, and I'm going to give you a little pillow to angle onto, with your head more like that. Yeah. So no, I see.
Where are you looking?
Like more like this. So you want to rotate and have your head, like
Oh,
that.
this
Yeah.
way.
That's
Okay.
it. That's it.
Gotcha.
Okay. So
Okay.
then the next would be to rotate, and then let's go ahead and let's look for some dysfunctions in the stretch, because now we got to stretch this way and rotate it.
Yeah.
And let's look for some dysfunctions.
So it's the old chicken or the egg. You could have a nerve root causing a muscle to have a problem, or a
And
muscle.
then the muscle could cause a nerve root.
That's right.
So the muscles could cause the nerve roots,
Yeah.
and the nerve roots could cause the muscles. Yes.
So
That's it.
How do you determine which one?
well, the Bodyworker
So
master
that
Bodyworker
they
does
spend
both.
$7 million on that, and of our taxpayer money, and they found that it's always the muscles, and sometimes it's the joints. Okay, so let's go ahead, and let's. So again, we're gonna. I'm just gonna go. So let's go straight. Just go straight this time.
Straight.
So one idea would be to go ahead, find the dysfunctions, and this side this is the side we saw more dysfunctions, and I could feel them right there, right here. Okay, so we're gonna go straight in. So we could just are starting a little bit above L5, so we're up higher in the T, and here we are on some pretty bad dysfunctions right here. And I'll switch to my knuckle here. So what does it feel like with the knuckle? What'd you say?
It's a tender area.
Yeah, she notices it.
That way.
Okay, and this is what we call myofascial pitting. You see, this is like really dead tissue. But I love myofascial pitting because then it's something we can fix.
We can improve it.
We can fix that. But you see, it's not edema.
Dead tissue?
It's like it's
Not
just
dead,
it's like temporarily. It's like
Sleeping.
it's just
Hibernating.
it's like that. You press on it.
All the
It doesn't-
little fascial units, they're not, it's like a rubber band that's kind of like not elastic anymore. It gets its elasticity back.
So
So
could
this
a
is our
neurologist
painful sign.
examine a patient and have them
they're
come up
not
normal
looking-
and still
They're,
have nerve
they're not
pain?
looking for heightened tone. They're looking for lack. Generally, I mean, they might look for something different than I'm saying, but I'm just saying in general, they're looking for nerve compression where there is no innervation. They're not looking for heightened innervation. See, this is heightened, so we're getting heightened tone, not wasting away. So we're looking for heightened tone, and that's causing height. So all the muscles that are with this, when you have this heightened tone here at the spine, all the muscles in this nerves distribution are going to be also heightened tone and have trigger points. They could be weak.
I just wanted to mention too again that if these kinds of problems come back, I mean, they just do. I mean, it's just absolutely notorious. The tight hip muscles, if you were to work out, do self-care on your glutes every day and your piriformis every day, lateral rotators, tensor fascia lata, the, lateral thigh, all these muscles, the hamstrings, they just come right back. People say, I stretch them every day, but it comes right back. You just have to realize that that is from the perpetuating factors.
Now, muscle could be a perpetuating factor, or it could be Morton's foot.
Yeah.
Or
And
lack of nutrients.
I do have Norton's foot.
Mhm.
Yeah.
Oh.
Okay, so it's feeling better. Okay, let's go ahead and let's test it. A few things. Let's
Okay.
see. So here's a little test. I got a little test here.
Okay.
Okay, so now after I treat it, I like to see if I can get it to do its contraction. So here I like to do that. So I'm getting it to contract a little bit. So see how we're doing. And we'll do also the twisting. So we're going to twist it different ways while I'm treating it. This is a really good way to see if you can get full function. Okay. Okay, let's do that twist this way. Remember we did it that way? Okay, so we're going to do it this way one more time.
So you felt there was not some twisting? There's some twisting restriction still?
I was just going to give her, I was just going to give her a little bit more on this position. There was a lot of stuff here.
Okay.
So tell me what you think of the painfulness.
Yes, she's talking about motion between the individual vertebrae and contractions of those intervertebral muscles. Yeah, exactly.
That's a little better than it was medial.
Yeah. So sometimes when you do it on the stretch, it's less painful.
And I'm just going to say one more thing about what brings this stuff back. Just because you've put the right foot, orthotics in, whether, just because you've got a metatarsal lift, all that stuff, I'm not kidding you. You have to do an overhaul on people's feet. Every single joint in a foot, you should be going through it and checking for its motion, working out the little, those little lumbricals that go in between the, in your feet.
And the little interossei.
The little interossei. You have to work those because they have likely been in pain and dysfunction for so long that if you don't overhaul the feet, it's really hard to make a total, complete correction of the back and hip. It just doesn't stay. Remember, every nerve, whether you feel it or not, but every nerve that's saying ouch. Remember, a lot of these ouches you're not feeling consciously, but they're sending ouch signals into your nervous system, into the spinal cord. Every nerve that screams ouch, whether you feel it or not, is causing dysfunction somewhere. It's causing the body to not move and stay in a state of protected, stasis. So you've got to get, when you poke around the feet and there's all these little sore spots, every one of those spots is saying ouch, is causing a bit of a problem.
Let's do our skin rolling again.
Oh, yeah.
Okay. Okay, so let's see how much improvement we had in our skin rolling. So
we really did a better job this time.
So it's coming up.
Yeah.
So we still have a few spots that would improve more. Okay, so here.
Yeah.
So here we could get this to roll a little bit more. Okay, so we're getting pretty good.
Yeah.
So a little bit more right here at about L4-5.
Yeah.
And then over on this side, more a little higher. So we still, let's take a look here and here, one more time. So let's go ahead and have you lean forward one more time. Yeah. So let's gonna go ahead. Let's look at these two spots.
Okay. And then after that, why don't we recheck the range of
Yes,
motion on the
let's do
hamstrings
it.
and the strength tests?
Let's do it.
Because I really like to show people how the hamstrings can be affected by these nerve roots.
And we could do the range of motion test.
Yeah, all the range of motion tests, exactly. Range of motion, yep. And remember, no muscle works alone. So if you have a hamstring that's overcontracted, then it's sending signals to shut off the quads. The quads will feel weak, and if you have tight quads, then you might have weak hamstrings. And, and then individual trigger points can cause the muscle to feel weak because it's not all contracting together at once. So you're doing such a wonderful service to these patients as you're combing through all this fascia. You're changing their lives in a lot of ways.
Okay, so today we're treating everything that causes back of the thigh pain.
Back at the thigh
Right.
pain.
Okay, so here we're gonna take a look here again.
So we were treating the
this-
nerve roots
mhm.
that cause back of the thigh pain.
That's right. That's better. Okay. Better. Okay, good. So I think we could keep looking at this and see if we can get it better. We got it rolling.
Okay.
Okay, now we're
Got it
gonna
rolling.
test some more. So let's see if you get, how you touch your toes.
All right.
After we treated a lot of the muscles. You already touched your toes before.
Well, that was with shoes on.
Yeah,
Oh,
that was with the
shoes on.
orthotics.
Now I could, yeah. so
Now she can touch without even
And
out the
also
shoes.
standing, but when she was sitting on the
Uh-huh.
table
It was,
and
it
touching
was
it
sitting I couldn't touch.
That's right. That's right.
Let's try
Standing
that.
I could touch.
Okay, so we get your little. Let's
See what
test you again.
Sitting can do.
And we didn't do a lot of work on the hamstrings. We just did a moderate amount.
Yeah.
But we did a good amount on the
Okay.
nerve roots, which I think
Right.
is
So
really
go ahead
cool.
and see if you go ahead and touch your toes. There. So let's see what we got with that, and that's about still 4 inches there.
Okay.
Okay, so let's go ahead and have you lay on your back.
And don't forget that's seated, so any kind of pelvis issue,
mhm.
like a small hemipelvis, that could
So
be causing.
we're going to turn in, and here you see we're about 3.5 inches, and oh, this one here is half inch on that one.
So they both improved a little bit.
Okay, so also let's go to the knee to the armpit test. Okay, we gotta get all of this. Okay, here we go. So here we're gonna measure. Here we go, and that's like 7 inches. Let's try on the other side. And again, that's about 7 inches on this side too. Yeah. Okay, so let's go ahead and test.
A straight leg raise.
Oh, let's do the straight leg raise. Yeah. Okay. Okay. So this is
Oh,
that's
that's
a little
better.
better
Oh,
there.
yeah, that's improved.
That's quite a bit better.
Yeah.
Okay. And here we go. Just comes right up. Okay.
Oh.
So
Oh,
it's
yeah.
coming up a little better. Yeah.
Okay.
So it wants to come up.
That is better.
So let's just. Woo!
Yeah. No, it wasn't nearly that good before.
Better,
That
better.
was good. That's good.
Yes.
Yeah, and should we try
So,
the straight test as well? Just see.
Yeah, we're gonna do that. We're gonna do that now. Okay.
that.
So let's see how we're
This
gonna
was
do.
the only one that was remaining. So
Right.
pull back at the heel. I'm going to pull 1, 2, 3. Okay, good. That's good. Did you want to try this one that caused that cramping? Push up and out. 1, 2, 3.
It's still cramping.
It's cramping, right? So you've got lots of more work to do on this. What did we find?
So that would be
Glutaminis,
so
right?
you were
Right here.
testing her on the TFL, but we didn't actually treat the TFL.
No, we didn't.
So we could treat the TFL.
Yeah, we could treat it too.
Yeah,
Well,
that's what's going
and
on right here.
and the glute medius and minimus.
That's a
Push
little
down and
different.
out.
Yeah, yeah.
Push down and out. Push down and out.
It's cramping just putting it in that position.
So okay, so
Let's treat it.
just as an idea, we can definitely treat that glute minimus
Oh, okay,
more.
okay, go
but
ahead.
what else? If one
Well-
muscle's cramping a lot, sometimes you look at its
we
antagonist,
we could do that.
which could be weak, and that could be the push in at this side, and I'm going to push out. This is the adductors. This side push. Yeah. So I didn't test that one before. So push
That was
in.
adductors.
Yeah. So if we've got a weak adductor opposing this abductor, then the abductor could cramp when we test it.
Right.
So then we know we did this last week. We're working here. You see?
Oh,
Yeah. See. Remember, I'm not pushing very hard. These
Oh,
nerves are screaming
very,
at her
very
nervous
tender,
system.
very
They're
tender.
screaming at her nervous system.
very,
She
They're
needs.
hypersensitive.
Yeah, they're screaming, and so she needs to get them to not scream because there's no injury here. It doesn't need to be screaming, so this needs work for sure. But we did that, like I think last week was the adductors, the week
yes,
before.
we worked on that last week.
Yeah. So so again, we're doing this part-wise, but we would send you home with a self-care protocol. Would definitely, we would never leave that like that. So even though we're doing it in
More
pieces,
adductors.
we would be doing probably every protocol the last 3 weeks, this week, last week, and the week before. You would have some things to do.
So
Yeah.
we could do the TFL treatment.
Yeah.
The TFL. So let's go ahead. We could do
Yeah.
that. Mhm.
Okay.
So we're gonna treat the TFL. What do you think of that?
Okay, yeah,
Let's
sounds
have you
good.
turn to the side. Let's look at that TFL. We'll put a little pillow under your head. What do you think of that?
I think that's a good idea.
Okay, so since the TFL is in the front here, we're going to stretch it a little bit. So we're going to take it this way. Yeah.
This
Okay,
way.
so yeah.
Okay.
So we're going to take a look at it right here. And so we got a good spot for us. Her TFL is right where my elbow is.
What's TFL?
Oh, tensor fascial lata.
Oh, yeah. Sounds like a coffee drink.
Yeah, tensor fascial lata.
It's right where your Colt 45 would go.
Tensor lata.
Where you draw, yeah. Where would you put your Colt 45? Right there, right? Right there. That's where it is.
Yeah, that's where
Colt
I carry
45.
it.
That's a neat way of remembering its innervation too. L4, L5,
She's
Colt
gonna
45.
shoot. She's gonna get her gun out.
That's right.
Shoot that pain away.
Shoot the pain.
See, you're shooting it up to the ceiling.
Yeah, that's the one thing that having short upper arms is good for.
Now that's relaxing.
Quick draw.
It's relaxing a little bit.
Short upper arms, you get a quick draw. All the best gunmen were all short first. Top leg is hanging off the table in the back. Yes.
That's relaxing.
And this is what the doctor said was bursitis, because
Well,
I couldn't lay
Yes,
on
that's
the
right.
left side.
So it often causes what appears to be greater trochanter bursitis.
Yeah, that's what she gave as a diagnosis.
The
And
question.
now we're laying on my
But
left side.
always you can fix it with treating, almost just all the time.
How would I price? Did you mean the right price? The person who just asked me that question. I can show you right now how I would.
Okay, let's have you lay on your back. I'm going to show how to stretch it, Justin.
Okay. How we stretch it?
So we're going to stretch the TFL. So we're going to put this leg here, so we're going to stretch the left
Oh,
TFL.
yeah.
So we're going to give it a good stretch. And go ahead and press towards Justin. Keep holding, keep pressing, keep pressing, keep pressing, keep pressing, keep pressing.
Yeah, she
And
has trouble
relax.
contracting those because of that.
And towards Justin. Keep. Oh, it's very strong. Oh my
Yeah,
God.
right?
She's strong as can be now.
I know.
She's strong as really strong.
I know.
Okay, stay there. Let's do it. So, then also, in this position, like it's nice stretch too. So you got this here stretching it. So I'm right on it. So I'm sort of bringing it back like that. Mm-hmm. So different positions.
How we would document this is say we had 3 pain protocols, then we would, on the charting tracking sheet, in slot 1 we'd put 21, and then we'd put 22 and 23,
And then important muscles.
we'd put the main muscles that we found that we wanted to work on, and then each visit we would make sure we would do that. And in the goal section we'd put the range of motion tests we wanted to pass. And I'm not sure if they meant to write price. Someone wrote, how would you price if you had 3 regions you worked on? We don't do it by region, we do it by time slots. We just do 45 minutes for the 15-minute time slot. So that's standards in Chicago area. And so, an hour is 180, an hour and a half is 270, and so on.
Okay. So shall we take a look at the strength of that one? Okay, so let's go ahead and we're going to take it out kind of like that. And go ahead and
You're going to push up and out, or here, down and out would be
down
more
and out.
minimus
down
medius.
Yeah,
down and out.
Down and out.
Yeah.
Okay. Okay.
Pretty good.
That's strong. Okay, I'm going to just go.
Yep. So push
Okay,
down
push
and out.
down and out. Down and out. Not
Still
there. Huh?
cramping?
Oh, there.
Well,
Yeah.
I
That one.
think that's going to require getting these adductors, because when it's cramping, it's in a shortened position.
Okay, let's do the adductors.
Yeah,
Turn that way. Turn.
let's do the
Turn this way.
adductors, because I think,
Turn this way.
yeah.
So bring this knee up. So this is the adductor treatment. So here it's attaching here on the ischial ramuses. And okay, so here we're going to go here. Let's go up and towards the ischial ramuses.
Because that test, it's short, the muscle's kind of shortened and it's cramping. So what if you made what if you made a guns, make your guns and your biceps cramps? That's likely a problem with the triceps being inhibited somewhere. When a muscle is shortened and it cramps like that, you have to check the antagonist. And you could tell this adductor is doing nothing. I mean, you couldn't hardly touch it, and it was really upset.
And I'm using a really broad pressure.
Right. I mean, it's not like she just had a 3rd-degree burn. It's not like she just injured it. I mean, there's no reason those nerves should be that upset. So even though they complain, you have to teach them not to complain.
Go through it.
Yeah, it's like, no, your job is to function as you were originally created. Which means you do this, and you do this, and you do this, and each little unit does this. That's what Sharon is saying. Sharon is educating the muscle.
Send them to school.
Yeah, send those muscles to school.
So a good way to get into this area is you get right by the ischial tuberosity and then the ramus. You're going up towards the attachment onto the ramus. And up into its attachment. And then down. And then you can come up into its attachment and then down. And you come.
And because the compaction had those muscles turned off for quite some time, possibly, not only the adductors, but a lot of those muscles could have that similar kind of
Go ahead and lift your leg up towards the ceiling.
inhibited sort of function. Ooh,
Okay,
that's
good.
better. See?
Nice, nice.
See? Look,
nice.
she lifted that up. That's another strength test for it, right?
Nice
Push up.
there. That's a good test.
All right, let's have you roll on your back. Let's test that adductor that was so weak a second ago. And we'll see. Okay, so your heel is going to go towards that heel. Push.
Wait, this
Heel. This way.
They go together.
Yep.
The legs go
Bring
together.
the legs together. Ready? This one. And 1, 2, 3. Okay, good. You see, you can feel it definitely contracts. Okay, should we try this one, see if it cramps?
Yes.
Push down and out. 1, 2, 3.
And a little bit.
A little bit. Less.
Less.
Push up and up. Push. 1, 2, 3. Yeah, not cramping that time. Just a little bit. Yeah.
little bit
So
toward the
so
end.
more work, obviously, but that's getting rid of that cramping.
Good.
Yeah. Beautiful.
So you do me one more time. So let's.
So the antagonist, protagonist.
So go ahead and push towards
Yes,
distance.
yes.
Push and relax
And don't forget the synergist.
and push and relax and push. Good. Can we stretch the ones that were stretched?
Yeah, she didn't want to leave it at a cramp.
Yes.
Yeah, she
Cramp
went,
it,
yeah.
then you
Cramp.
would do the
You're gonna
opposite of
stretch it.
cramping.
Yeah.
Yeah. Okay. Well, let's do a little bit of range of motion exercise.
Oh yeah, that's it.
Alrighty.
Let's
Range
go
of
ahead,
motion.
Turn to the one side and let's go ahead and sit up.
Should we have you guys line up or what you?
Yes, we should.
All right, everybody do some range of motion.
Okay, so let's do it. Okay, so
Should I get some music?
okay. Okay, where do you want to be here?
Wherever you'd like me. Here? Okay.
Okay, so let's together with our right legs. Okay, so our right legs, so we're going to turn our toe in, turn it out, turn it in, turn it out, turn it in, turn it out, turn it in, turn it out, other side, turn it in, turn it out, and in, and out, and in, and out, and in. Good. Let's do our hamstrings. So for that, we're going to put our hands behind our back. We're going to have like a flat back, because that's going to get our hamstrings down our back as much. So we're taking the back out, and we're going to stretch the hamstrings. And so we're going to just give it a little bit of bounce. And it's all bounce to the right. And a little bit bouncing towards the right. And towards the middle. Come towards the middle. Give a little bit of, like you're picking with the other side.
The henpeck stretch.
Okay, so we're going to go ahead and we're going to go to the left. Then we're going to go to the right. And to the left. And to the right. And to the left. And to the right. And to the left. And the right. Good. Walk with our toes in. This is a good exercise. Toes out. Toes in. Toes out. Now this is called the hip twist. So you're going to go turn your hip all the way in and look at your hip. And out. Together, all together in. Look at your hip. And turn it out. In. Out. In. Out. In. Out. In. Other foot. In. in, out. Look at your hip. In, out. Look at your hip. Now together. In, out. And look. In, and out. Good. Side, 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 side. Come down. And bend your knees. Straighten. Bend. Straighten. Bend. Straighten. Bend. Straighten. Good. And come up. Now vertebrae by vertebrae. Vertebrae by vertebrae. Now a little bit far, a little lower lumbar and sacral vertebrae. We're going to rotate, 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 rotate. A little higher. A little lower. And we're going to go ahead and we're going to do some little pelvic tilts. So we get our pelvis go forward and back. And forward and back. And forward and back. Side to side. Side, 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 side. And all the way around. And the other way around.
All right, perfect.
You ready for our song?
Yes. We're ready, we're ready, we're ready.
I was going to say for the funny.
You're welcome, everyone. Thank you.
Sharon and Justin from Pain Free.
Okay. So up and down.
Remain free. We will assess and use heat
And back. Okay. You need a full range of your wrist.
and
Full range of your wrist.
repeat. When I
And you gotta get your thumb to go behind your mouth.
is there, we'll
You
teach
need to get
you how to do self-care. This will keep you at your peak. So see you back again next week.
Thank you, everybody. Thank you.